Please start the presentation, Doctor.
Good evening, everyone. I'm Dr. Sanyal from Ambedkar Medical College, and I'll be presenting a case on obstructive jaundice. Next slide. An 80-year-old male, shopkeeper by occupation, resident of Chikbalapur, presented with complaints of pain in the upper abdomen for 20 days, fullness in the upper abdomen for 20 days, yellowish discoloration of the eyes and the skin for 7 days, and itching all over the body for 7 days. History of presenting illness. The patient was apparently asymptomatic 20 days back when he developed pain in the right upper abdomen, which was insidious in onset, dull aching type, continuous in nature, and non-radiating. It was relieved on taking medications. However, there were no aggravating factors. He also complained of fullness in the upper abdomen for 20 days, which was insidious in onset and non-progressive in nature. The patient gives history of early satiety with loss of appetite and loss of weight for 15 days. There is also complaints of yellowish discoloration of the eyes and the skin and presence of dark colored urine, which was associated with generalized itching of the body for 7 days. There was no history of fever with chills and rigor. There was no history of vomiting, passage of blood in stools or clay colored stools, no history of neck swellings, no history of cough, blood in sputum or back pain, and no history of altered bowel habits. Past history, there was no history of diabetes type 2, hypertension, tuberculosis, ischemic heart disease or asthma. There was no history of jaundice in the past or history of surgery in the past. And there was no history of previous blood transfusions. No significant family history was found. Personal history, his diet was mixed type. He had reduced appetite and his sleep was disturbed. Bowel and bladder habits were regular, but higher colored urine was present. The patient is a BD smoker since 20 years, taking 12 BDs per day, and the last smoked BD was 20 days back. And he's also non-alcoholic. I would like to summarize my case. An 80-year-old male chronic smoker presented with fullness in the right upper abdomen, which was associated with pain for 20 days, with loss of appetite and loss of weight for 15 days, and yellowish discoloration of the sclera and the skin with high colored urine and generalized itching for 7 days.
Okay, Dr. Arjunan, any questions so far?
Dr. Sanyal, based on this history, what are the probable possibilities that come to your mind clinically? What are the clinical diagnoses that may come to your mind with this history?
Sir, it appears to be in case of obstructive jaundice, which could be probably because the duration of history is short. So probably with malignancy. However, we need to find out whether it is what is the cause, where is the site of malignancy, whether it is a primary malignancy or due to secondaries. At the same time, sir,
don't you think presence of pain makes it difficult for you to make a diagnosis of malignancy? No, because pain is usually a late presentation.
Yes, sir.
And the duration is very short.
Duration is very short, sir. Yes, sir.
Is there any history of weight loss? Did you ask specifically?
Yes, sir. There is history of weight loss for 15 days as per the patient.
Dr. Ravishankar.
Yeah. Yes, sir.
Sir.
Yes,
see,
sir.
He has not mentioned how much a weight loss. One. Second thing is the discomfort of pain, upper abdomen. I think she should specify in the history of presenting illness which part of the abdomen. Is it hypochondrium, epigastrium, etc.? That's very important. They should mention where exactly is it, and also fullness in the upper abdomen. Again, is it right hypochondrium or epigastrium?
She's mentioned it as right upper abdomen, so probably
no, she said upper abdomen.
No, but if you look at it,
right upper abdomen. Yeah, she didn't mention right hypochondrium, right?
No, yeah, but because history is in the patient's own words, that is why she's probably said it as right upper abdomen.
If presenting illness, they should be able to transcribe that into a medical terminology.
Okay, sir.
That is what we expect. The patient points to right iliac fossa. In appendicitis, we say pain in the right iliac fossa.
Okay, ma. Dr. Ravi, anything else to add?
No, this I would like to differ in this particular thing. What this history of presenting illness, the classic standard teaching is it should be told as far as possible in patient's own words and in layman's terms. We cannot introduce technical terms like right hypochondrium or right iliac fossa in the history of presenting illness. The standard teaching from the many years has been it should be in patient's own terms. So as far as possible, I would advise that patients stick to the what she has told is right upper abdomen is correct, wherever the patient has pointed out. The patient will not tell unless he is educated, like I'm having pain in the right hypochondrium, I'm having pain in the epigastrium. He will not complain like that. So whatever patient's own words we should use in the history of presenting illness. Of course, when it comes to examination, then you can use the technical terms. This is the standard teaching. So I think you should use the patient's own layman's terms as far as history of presenting illness is concerned.
Dr. Srinivas,
Actually, the right hypochondrium is a very small area. It's smaller than we think. If you look at it in the chart which we draw with those lines, the two lines, transpyloric plane and the other line, and the vertical lines, the area is very small. It is smaller than our fist, that much small area. So using right upper abdomen is acceptable to us.
Okay. Right.
Acceptable. To me, it is at least acceptable.
Other thing is, you said about no history of type 2 diabetes. I don't think you should specify as type 2 diabetes. Diabetes is sufficient because how will the patient know whether it's type 2 or type 1? So I think it's just, you just say no history of diabetes. Type 2 is not probably required. Okay. I think
Sanyal, considering the history of pain abdomen, would you like to consider CBD stones as one of your possibilities? You said only malignancy. Obstructive jaundice, right? Accepted. Would you like to consider CBD stones as one of your possible diagnosis?
Yes, sir.
Because there is history of pain in the right upper abdomen.
Yes, sir. CBD stones can also lead to
that should be your first, because it's a short history, 20 days duration. Okay.
Okay, sir.
And the weight loss is the only since 15 days, and you have not mentioned the amount of weight loss, whether it is significant or not. And loss of appetite only since 15 days. So the pain abdomen is there, which is a short history. You should also consider CBD stones as a possibility at the history level. Okay. At the history level. What you said, the other thing, malignancy is one of the possibilities. Yes.
Dr. Harish, Dr. Kanagavel, is he there?
Yes, sir. Is there Kanagavelu, sir?
Good evening.
Good evening, sir.
Good evening, senior colleagues. And I agree with the thoughts which I've shared by that. Doctor, can you go to the first slide? I'd like to ask a couple of questions there.
Yes, sir.
See, when you talk about pain in the upper abdomen, can you describe what are the potential types of biliary and pancreatic pain? How do you differentiate between these two?
So whether it is a biliary colic.
Yes. Can you explain about what is biliary pain, what is hepatic pain, and what is pancreatic pain? How do you differentiate from history?
So whether the pain is continuous or it is intermittent.
Okay. So if it is a continuous pain, what does it imply?
So hepatic pain.
Okay. So what are the potential conditions from liver you can get pain and jaundice?
So if there's for example, a large infected hydatid cyst, which can be.
Let us talk common things first. Yes,
Okay,
what you are telling is potentially possibility. More common things first.
Secondaries in the liver, sir.
The first thing is acute viral hepatitis.
Viral hepatitis, yes,
that
sir.
is a common thing. Then the next thing is potential abscesses of the liver.
Abscess, yes,
right?
Sir.
In this case, considering the background of obstructive jaundice, and all the faculty have been pointing out one more diagnosis beyond the malignancy which you are talking about.
Yes,
can
sir.
some part of cholangitis produce continuous pain?
So cholangitis can present, but there will be additional features like fever will be there, which will be.
Right now we are discussing about pain. Cholangitis, when they are fairly advanced, they become cholangiolar abscesses. They produce continuous pain. Then coming down to the biliary pain and the pancreatic pain, what are the conditions in bile duct and what are the conditions in pancreas which can give continuous pain?
So if there's a pseudocyst of the pancreas, that can cause an
Pseudocyst per se does not give pain. Infected pseudocyst can give pain.
yes, sir, infected
So
pseudocyst.
first thing commonly happening is if there is an obstructive jaundice, you are first concerned about acute pancreatitis, right? So
Yes, sir.
let us discuss in pertinence to this case. So acute pancreatitis could be the entity. Number two, if it is a possible head malignancy or body malignancy coming into the head, blocking your bile duct, infiltrating pain, especially when the pancreatic tumor infiltrates into the celiac plexus and the peripancreatic neural plexus, they gives continuous pain. And the last thing is when the pancreatitis worsens, when there is an infected collection or an infected necrosis, they produce continuous pain. Okay, now you have fairly discussed about all these things. What are the conditions which cause intermittent pain in the hepatobiliary region? You said biliary colic. Can you explain little more about biliary colic? Are you with us, doctor?
Yes, sir.
Yep.
Sorry, sir. Not.
No problem. Did you hear my question?
Yes, sir. Yes, sir.
Can you describe what is a biliary colic?
Sorry, sir.
Simple
Okay, don't
condition,
worry. Biliary colic is a typical pain, which is a colic, definitely with a very severe pain. Usually happens following a intake of a fatty meal or a oily food substance,
Yes,
or a
sir.
potentially highly protein-rich food also can be a cause. And most of the time, unless the obstruction, the reason for the cause of obstruction is relieved, the pain continues, and then they invariably are relieved only with some form of antispasmodics or analgesics. All right.
Yes, sir.
Fine. This part is over. Now, as we move, you talk about pruritus. Can you explain
Pruritus.
what is the reason for pruritus in obstructive jaundice?
So because the bile acids gets deposited in the free
Bile
nerve
acid?
endings. Bile salts, sir. Bile
Okay.
salts.
Can you tell what are the potential bile salts a body can secrete?
So sodium. So sodium taurocolic acid and
Sodium
sodium.
glycocholate and sodium taurocholate.
Sodium.
So where
Yes.
exactly these things get deposited under the skin?
So they are near the free nerve endings. That is why
And
they
is there a
cause
layer?
irritation.
So the elastin and the desmin layer where the
Desmin
salts
layer.
get
Yes, sir.
deposited and activates what mechanism? Why you get intense itching? There is a pathway because of this salt. They irritate the nerve pathway. Can you
Yes,
recall
sir.
that? Okay, fine. You should be thorough in these things also, right?
Yes, sir.
And one more thing, can you explain when a patient, you said no history of clay-colored stools,
Yes, sir.
right? Does it help us to understand whether it's a partial obstruction or a total obstruction? Can you correlate with your case when there is no clay stools?
Sir, since there is no clay stool, so it's complete obstruction.
No. Please think before you answer this question. I'm not in a hurry. Please think yourself. What does a clay stool manifest? Why does it manifest at all?
So because the deconjugation doesn't occur because
Why does deconjugation does not occur in obstructive jaundice?
So the conjugated bilirubin is not reaching the intestine where the deconjugation
So that means
occurs.
what happens? There is total obstructions or no obstruction?
So total obstruction is there.
Okay. So what is happening in your patient then?
Sir, total obstruction is not there. So that is why some amount of deconjugation is occurring, and therefore.
So what are the conditions or what are the potential obstructive jaundice conditions which can be partly producing obstruction? So you should think about it before coming into a conclusion, right? So
Yes,
that
sir.
is why your other senior faculty have been pointing out you should always have a potential second diagnosis of a stone disease.
Stone.
And
Yes,
then
sir.
there is one condition which can give intermittent obstruction. What is the condition which apart from stone which can produce intermittent obstruction? Have you heard of a tumor around the ampulla? What is they called? What are they called?
So periampullary.
What happens in
yes, sir.
periampullary carcinoma?
So in periampullary carcinoma, there is obstruction to the distal CBD, but depending on the site of the carcinoma.
Okay.
So if it
No,
is yes, sir.
Is there it is a type of a remittent type of jaundice in periampullary carcinoma? Have you heard about
So
it?
there'll be waxing and waning in case of periampullary carcinoma.
Why do you call that? What is the principle behind that waxing and waning?
So as the tumor gets sloughed off, there is
So the
a decrease
tumor
in the bilirubin.
outgrows the vascularity. That is
Yes,
the
sir.
right word. Okay, I now
Outgrows the
hand over to the
vascularity.
other faculty. Thank you.
Dr. Ravishankar,
Yes, sir.
did she mention progressive jaundice?
Yes, sir. I think she said the jaundice is not progressive. That's what she said.
Not progressive.
Non-progressive. Yeah.
Now we are looking at possibilities of hepatitis, choledocholithiasis, and possibly malignancy.
Malignancy. Yeah.
Yeah, we do not know where the malignancy is.
Yeah. So these are the
Very possible.
See, most of our patients are rural background. Especially where I am practicing, it's rural areas where patients come. They have open field defecation, and that too they go out in the night. They are not able to actually ascertain the color of their stool.
Correct. Yeah.
In our rural population, you should take it with a word of caution. This one, the color of the stool.
Yeah.
Normally, none of the patients get it right. Actually, they'll be having all sorts of
yeah, I agree, Dr. Pai. What they should
difference in diagnosis.
Anyway. What they should say is that you should also make sure that the examiner knows that you asked about it, and the patient is not able to say it. That's all I think. That is, I think the examiners will accept that.
Basically, the diagnosis on that single point is a little.
No, I think it's just I think what Dr. Kanakavel was doing was to take the student through a methodical process of history taking.
Yes.
I think that's fine.
That I agree.
I think that's fine. I think, thank you, Dr. Kanakavel. You can go to the examination now.
Yeah, I think we have to quickly go to the examination so that we can go on with the discussion.
Yeah. Okay.
Coming to general examination, the patient was examined in broad daylight, well exposed from the nipple to the mid-thigh after taking proper consent.
Can we go ahead with the positive findings, sir?
Yeah.
Positive findings, doctor.
So one slide back, sir.
Okay.
So icterus was present, scratch marks were present, and bilateral pitting edema present. No generalized lymphadenopathy. Next slide. On per abdomen examination inspection, yellowish discoloration of the abdomen was present. An ill-defined globular mass is noted in the epigastric region, which is extending up to the umbilical region of approximately 15 into 10 centimeter. And this is extending approximately 10 centimeter from the xiphisternum inferiorly. It moves with respiration. The umbilicus is displaced downwards and is inverted. The corresponding quadrants move with respiration. There is no visible scars, sinuses, pulsations, dilated veins, and no visible peristalsis seen. Bilateral hernial orifice and external gelatina are normal. On head raising test, the mass becomes less prominent. The left supraclavicular fossa shows no fullness. On palpation, the inspectory findings are confirmed. There is no localized rise in temperature. The tenderness is felt in the epigastric and the right hypochondriac region. A solitary globular mass of 15 into 10 centimeter is palpable in the epigastric and the umbilical region, which is extending to the right hypochondriac. And this is 10 centimeters from the xiphisternum vertically. Horizontally, it extends 4 centimeters from the right costal margin in the midclavicular line and 2 centimeters from the left costal margin in the midclavicular line. It has smooth surface, is tender, firm in consistency, wherein the superior border is not appreciated and the inferior and lateral borders are well defined. It moves with respiration and is non-pulsatile. The fingers cannot be insinuated below the right costal margin. Next. The liver is palpable in the right hypochondriac, 5 centimeters below the costal margin in the midclavicular line, is tender, has smooth surfaces, sharp edges, is firm in consistency and moves with respiration. The mass was palpable to be continuous with the liver. There is no other palpable mass or organomegaly, no cough impulse. Bilateral renal angles are free. The external genitalia are normal, and the left supraclavicular fossa shows no lymphadenopathy.
Okay.
On percussion, the liver dullness is 15 centimeters in the mid-clavicular line. In the right mid-clavicular line from the 5th intercostal space to 5 centimeters below the right costal margin. And the dullness is present over the mass, which is continuous with the liver dullness. No free fluid is noted. On auscultation, normal bowel sounds are heard and no brew heard. Per rectal examination, the perianal region is normal. DRE shows sphincter tone is normal and there's no growth. Fecal staining is present. Examination of the other system, CVS is S1,
Yeah,
S2
it's okay.
heard.
Yeah,
Yes,
it's
sir.
okay. So what
Yes,
is
sir.
your summary, give us a summary of the clinical examination. History,
Yes,
you've
sir.
already done that.
Yes, sir. Sir, an icteric patient with the globular mass palpable in the epigastric and the umbilical region, extending into the right hypochondriac of size 15 into 10 centimeter with smooth surface, which is in continuation with firm consistency, along with hepatomegaly present.
Okay. Dr. Pai, anything you want to ask in terms of the clinical examination?
Is globular mass the same as the liver? Is it continuous with the liver?
Sir, she
Sir,
did tell, sir. She did
Yeah,
tell.
she said it is continuous with the liver.
See, we'll finish this and then I have a small suggestion at the end of this, at the end of the discussion. Okay.
Dr. Arjunan, anything to add or any questions in the clinical examination?
Oh, she has done a good presentation as far as the examination findings are concerned. So we can proceed to know the diagnosis from her side. What is
Yeah. Yes, Dr. Srivatsa. Dr. Srivatsa, anything to add?
Ravi Venkat here.
Yes, sir.
Why do they write only left supraclavicular lymphadenopathy? Why not right supraclavicular lymphadenopathy?
Can you answer that question, Ma?
Sir, because of the metastasis occurs to the left supraclavicular nodes.
Why does the metastasis happen in left supraclavicular nodes? Why doesn't it go directly to the blood?
Venkat, you please.
See, you have to understand that when the disease goes to the, it goes as emboli, there are supposedly valves at the thoracic duct insertion. Only there. Okay, because of that, there can be reflux of the tumor into the surrounding tributaries, lymphatic tributaries, for which reason there is likely that it may go to retrograde to the supraclavicular nodes. I would examine both right and left supraclavicular nodes because there is sometimes the thoracic duct, the right jugular trunk may be a dominant duct. It may be draining part of the thoracic duct. So you may not feel it more often, but once in a while, there can be a right supraclavicular node. Please examine both sides of the neck.
Okay, Dr. Kanakavel, anything to add?
Kanap, I would like to know what is the color of the motion. You said fecal staining because Spicer was imparting about the importance and the patient educational status regarding the color. I didn't see your slide mentioning anything about the color of the stools because this is an opportunity to confirm the color of the stool so that it gives you a clear clue.
Sir, the color was brownish yellow, sir. It was
okay, you should
normal
mention that,
color,
right?
sir.
Especially in this patient, you should mention
that.
Right.
Okay.
I would like to also tell about no pelvic deposits, right? When in this patient specifically, that is what you should mention. And to add up to Dr. Shankar sir's and other faculties thing, I would also request you to talk about the axilla status. So is there any node in the axilla or not should also be mentioned. This is from my side. I think we will move on with the other faculties.
Yeah. Okay, good. What is the diagnosis?
Sir, it's a case of obstructive jaundice, which might probably due to malignancy, probably liver in origin, sir.
Why do you say that? How do you justify your
hepatoma?
Are you talking about the hepatocellular carcinoma?
Yes, sir. So one provisional diagnosis is
justify your See, nobody will question you if you make a diagnosis, but you have to be able to justify your answer.
Yes, sir. So the one is that the liver is the palpable mass is smooth surface, and it is in continuation with the liver on percussion.
Yeah. Okay. But which liver mass would give you jaundice? I think you heard Dr. Kanakavel. I
So
think
along yes, sir, along with this, they can be metastatic deposits causing which is causing obstruction at the porta hepatis level. That is why there is of jaundice, features of jaundice. One is that, sir. Second, it could be because of secondaries in the liver from primary could be in the stomach, or it could be in the pancreas, and along with the metastatic deposits.
Doctor, sorry for interrupting. What is the surface of the liver?
So surface is smooth, sir.
In obstructive jaundice, is the liver always enlarged? Even if it is not malignancy? Is there any reason for the liver to be enlarged without malignancy being there? Without the, what I mean is without the cause being malignancy. No of pancreas, no periampullary carcinoma. Can the liver be enlarged even in a calculus?
Yes, sir, because of the back pressure of the bile leading to hydrohepatosis. Sir.
Hydrohepatosis. Is that, can it occur in malignancy? Hydrohepatosis also? Yes.
Sir, if there's if the mass is causing it's pressure effect, sir.
Yeah, the same time I'll tell it's more likely in the liver to be enlarged in malignancy because of what you said, hydrohepatosis, isn't it?
Yes, sir.
So second, this is a late finding, isn't it? Your jaundice is 15 to 20 days, if I'm not mistaken.
Dr. Sanyal,
7 days, sir.
Yeah. Dr. Sanyal, your first part of the diagnosis is acceptable, obstructive jaundice.
Yes, sir.
But can you put it more precisely? See, you have described the mass in the epigastric region extending up to the umbilical region.
Yes, sir.
Preferably, you should be able to tell what is that mass anatomically, whether it's a liver or you are thinking of anything else, because you have described it separately from the right lobe of the liver. You are saying right lobe of the liver is descending down 5 centimeters, whereas
yes,
this you have described it as a separate mass.
Yes,
is it part of the left lobe of the liver? Are you thinking as anatomical diagnosis, or are you considering something else? That you should be able to tell. Your first part of the diagnosis, obstructive jaundice, is acceptable, but you should be able to tell what is the anatomical diagnosis of the mass you have described in the epigastric region. So that would lead you to the next point of discussion.
Sir, okay.
See, the problem is you have mentioned when you describe the mass, it is smooth and it is tender, and the borders are well made out. It's not irregular, hard. It is, you said it firm in consistency.
Firm in consistency, sir.
Yeah. So can this be gallbladder? Can this not be gallbladder? And it will be continuous with the liver dullness, and it will be moving with respiration. And you can have, as Dr. Pai said, hydrohepatosis you can have because of the obstructive jaundice, the liver can be enlarged. Why can this not be gallbladder?
So what is your anatomical diagnosis about the mass?
Pardon me, Sonia, what is it? What do you think it is then?
Sir, anatomically, the gallbladder, even if it gets enlarged, will stay in the right hypochondrium, sir.
But here?
Here, the mass is arising in the epigastric region, and that is extending towards, it is involving the umbilical as well as the right hypochondrium. But the mass is...
it also, isn't it? There's no step sign.
Yes, sir.
There's no step sign, and it is
not
possible to insinuate under the costal margin.
Not possible.
Epigastrium. So you consider it as an asymmetrical enlargement on the left-hand side and hepatomegaly on the right-hand side. That means there is a mass in the liver apart from hepatomegaly. Now, can you not consider that as a secondary due to something else outside the liver?
Yes, sir. That is also one of the provisional that they could be secondaries in the liver, where the primary could be either in the stomach, gastrointestinal.
Isn't there nothing in the bile duct?
Yes, sir. It could be an it could be a cholangiocarcinoma, intermittent cholangiocarcinoma. Sir.
Yeah, high up or low down. I mean, you should be able to place it above the cystic duct or below the cystic duct.
Okay, sir. So
what do you think?
Below.
Dr. Sanyal, you still not answered my question, whether it's the
Yes,
enlargement of the left lobe of liver, as Dr. Srivastava pointed out, asymmetrical enlargement of left lobe of liver, along
Yes,
with
sir.
the hepatomegaly on the right side, or
Yes,
as
sir.
Dr. Ravi Shankar pointed out, is it, would you like to consider it as a gallbladder enlargement? Because
No,
initially
sir,
it's globular, smooth surface, this
Sir,
moving with respiration.
Yes, sir. Sir, I would consider it to be liver in origin, probably a primary, sir, because first is the anatomical site of the gallbladder. So that is usually in the right hypochondrium, even if it is enlarged. And
So gallbladder is ruled out.
Yes, sir.
Yeah, I think we agree.
And,
We agree. I mean, I would agree that it's not gallbladder. But why do you keep saying it is hepatoma? Hepatoma doesn't produce obstructive jaundice. Unless
sir,
it's so close to the common hepatic duct and occludes the entire common hepatic duct. So something is outside.
sir, there could be metastasis to the porta hepatis, which is causing the obstruction, leading to the jaundice.
Hepatoma, very uncommon.
Sir, if it is hepatocellular carcinoma, then
so Sonia, the thing is,
kids is what
you have a condition called, when there is obstructive jaundice, you can have a condition called atrophy hypertrophy complex. One lobe of the liver hypertrophies, other lobe atrophies. Do you think this is just a hypertrophy of the left lobe of the liver?
Sir, I'm not sure, sir.
Dr. Ravi, what do you think?
Your findings are typically pointing out towards enlargement of the left lobe of liver. Okay.
Yes, sir.
And you have ruled out, you're also not agreeing with gallbladder. We are also not accepting gallbladder. So we can consider it as part of the left lobe of liver enlargement only, along with obstructive jaundice. Okay, that should be your provisional diagnosis at the end of clinical examination. So mainly important things whenever you encounter a mass abdomen is, first you have to give your anatomical diagnosis along with obstructive jaundice. What is anatomical diagnosis of the mass, whether it's arising from the liver or etc. etc. Number two, any other differential diagnosis you would like to consider. And number three, most importantly, you should be able to tell the pathological diagnosis. Here the pathological diagnosis is questionable because per se hepatoma will not cause so much of obstructive jaundice. As you said, one of the other possibilities is periportal nodes causing extrinsic compression over the CBD, causing jaundice may be a possibility, but that has to be further evaluated. So these are all the possibilities you can consider at the end of your examination. So now would you like to put it in a better way? Your diagnosis, your provisional diagnosis, would you like to put it in a better way? Instead of saying probably liver origin, you should be more categorical when you're giving your diagnosis at the end of examination. You cannot say probably liver origin. Okay, you give your DD, probably liver means, okay, first DD is liver. Second DD, I would also like to consider gallbladder like that. So you should be able to give obstructive jaundice with enlargement of the liver. Yes, agreed, hepatomegaly. Or you would like to consider gallbladder. That if it is so, you should give the reasons why it is a gallbladder enlargement. That should be the way you should give the diagnosis at the end of examination, because you got hardcore findings there. Okay.
Yes, sir.
Yeah.
So modify your diagnosis now. What do you think it is?
So it's a case of obstructive jaundice, probably due to malignancy arising from the left lobe of the liver, sir. I would directly jump to the.
Dr. Ravi sir very clearly said, hepatocellular carcinoma will usually not give obstructive jaundice. Again, hepatocellular carcinoma spreading to lymph nodes in the porta is quite late in the thing. It's not very common. Yeah, it's not very common. So the scenario you are painting is not the common thing. See, it may turn out to be that, but the examiners are assessing how you are able to, in a methodical fashion, come to a reasonable diagnosis which is plausible.
Okay.
Yes,
Can I suggest a diagnosis so that she can proceed?
Yes, sir.
See, considering 80 years of age, even though there are no signs of symptoms of cholelithiasis, I would put it as gallbladder with metastasis and infiltration of CBD or CHT, or a Klatskin's tumor with a metastasis to the left lobe of liver.
Yeah,
Okay,
I think
sir.
that may be. Dr. Pai, what do you think?
I fully agree with Dr. Srivatsa.
Yeah.
Professor Srivatsa. You can explain everything in it. You can explain the obstructive jaundice. You can explain the one side of the liver only enlarged with the secondaries and all other findings. Now, I have a suggestion. It's not a teaching to Dr. Sanyal. Okay.
Yes,
Are you able to hear me? Never
Yes, sir.
let your obstructive jaundice case be discussed as a mass abdomen. Okay. What is the case?
Okay, sir.
Obstructive jaundice. So
Yes, sir.
a lot of time spent only on the mass. Okay. So what
Yes,
you
sir.
should do is you should commit to the organ straight away instead of the mass. The case is not mass abdomen. No. Is the liver
No,
always
sir.
enlarged in obstructive jaundice? Yes. So first you present the liver. You commit it. It's the liver. And you describe its surface, and others might not agree with me, but at the end, let them give that opinion. You discuss it as the liver first. Then can the spleen be enlarged in jaundice? The answer is yes. Even though in obstructive jaundice, spleen can be involved in malignancies which involve the portal or splenic vein. Okay, head of the pancreas.
Yes,
Number 3, always commit on the gallbladder. Say whether the gallbladder is palpable or not. Then any other masses which are there. Instead of describing masses in obstructive jaundice only. If your case is mass abdomen without a jaundice, then discuss it as a mass. You understood?
Okay, sir.
Otherwise, what will happen? Your discussion will be only on describing what mass it is and what it is not. What Professor Srivatsa said, that should be your diagnosis. You know why? Because you can explain everything. You can explain the one side liver only enlarged, explained by metastasis, obstructive jaundice explained by the cholangiocarcinoma, incomplete jaundice because that also sloughs off. Might not produce melena like the other periampullary one, but it also sloughs off and might not be a partial obstruction always, might not be a total obstruction. Okay. And in cholangiocarcinoma or Klatskin's tumors, that is above the cystic duct, you won't get a gallbladder also. And you won't get splenomegaly because it's too high up to involve the splenic vein or something like that. You understood?
Okay, sir. Yes, sir.
Oh, you understood? This is just an opinion. Okay. It's just a method which I'm teaching nowadays to students. Never let obstructive jaundice be discussed as a mass abdomen. You commit to liver, commit to spleen, commit to gallbladder straight away, and any other masses you are feeling. And do not use the word organomegaly. I have a strong objection to using the word organomegaly in surgery. That's a physician's way of describing things because he has to rule out many organs. But for us, those organs has to be described individually. And like Ravi sir said, they have anatomical diagnosis, have findings. So whenever you tell some organ, there will be some findings which will make you tell it's that organ. You understood?
Yes, sir.
Thank you. Thank you. I would definitely agree with Dr. Srivatsa about the diagnosis.
Okay, can we go on to the investigations? Yes. So what's your opinion on these investigations? LFT?
Sir, I would like to get liver function test done, sir, to find out whether it is obstructive or...
On this slide, what's your opinion?
Sir, the direct total bilirubin is high with the direct component.
Obstructive jaundice confirmed on LFT.
Yes, sir.
Why? Why?
Sir, because of the direct bilirubin more, sir, compared to the indirect.
And that is one. And what else?
And sir, alkaline phosphatase is also raised.
More than?
So more than More than 4 times, sir.
More than 3 times. Okay. Right. All right. Okay. Now, after this, what investigation you want to ask?
Sir, I would like to go forward with the.
Just see, you got a total count of 22,000, which indicates that the mass in the left lobe could be an abscess also. Obstructive jaundice, abscess in the left lobe.
Abscess.
That's also a possibility. You know?
Yes, sir.
Okay.
Yes, sir.
So, what is the next investigation?
We are left with 5 minutes. To summarize the management.
Ultrasound of the abdomen and
ultrasound. Okay, what does the ultrasound give you? What information will it give you?
So it will tell us about the site of the obstruction, the size and the site of the mass, about the common bile duct, and if there is sir, about the surrounding structures, if there is presence of ascites. Yes, sir.
It will also tell you about the status of the gallbladder, multiple
status of the gallbladder, of the pancreas,
presence of stones, and also the head, especially the head of the pancreas. It may give you information, intrahepatic biliary dilatation, extrahepatic biliary dilatation. I think a lot of information can be gleaned by ultrasound of the abdomen. See, Dr. Sanyal, somehow I get the feeling you have got the CT scan and your clinical presentation has been tailored to the CT scan rather than going about in a methodical fashion. That should not happen. That should not happen.
Dr. Sanyal, can you go back to the previous slide?
Yes, sir.
See, you mentioned CA99, more than 1,000 in this case.
Yes, sir.
What does it signify?
Sir, it is raised in cases of colonic cancer
colonic.
also.
No, not colonic.
Cholangiocarcinomas?
Cholangiocarcinoma, yes, sir.
See, you yourself have mentioned, so you should be able to answer that. No, CA99 is basically elevated in all cholangiocarcinomas. And secondly,
yes,
pancreatic carcinoma. Okay.
Yes, sir.
So in this case, both AFP and CA99 are elevated. Now you go to the next slide, CT scan. And then you can mention the findings here.
Sir, CCT.
Yeah, please read out the important parts.
Sir, that liver is enlarged approximately 160 millimeter with a large mixed density noted involving both the lobes, measuring 150 into 86 into 93 mm with peripherally solid nodular component and central necrosis. And the lesion shows heterogeneous peripheral contrast enhancement on arterial, venous, and delayed phase and central non-enhancing component. It also has mass effect at the portal vein and splaying of the right hepatic and middle hepatic veins, and the intrahepatic biliary radicals are dilated.
Okay. What other investigations would help you to, make the, why is the patient jaundice then?
And there is no mass effect on the common hepatic duct. So it's the mass effect on the hepatic veins.
Yes, sir.
So how do you explain the jaundice?
Very significant obstructive jaundice.
Ravishankar sir, can you please summarize and
sir, the lymph node status was not mentioned in the CT. So
see, I think Sanyal, your presentation was good, but it gave the impression that you have gone, retrograde from the CT scan report and you have tailored your findings to that. And you were not able to explain a lot of clinical findings that you have actually presented well. So I think once, eliciting the clinical science is a very good starting point, but you should be able to coherently put the findings and then give a plausible differential diagnosis. We don't expect you to give us the correct diagnosis because many times even professors are not able to get that. But what they look at is the approach as to how you go about, coming to a reasonable conclusion in that order. So I think, unfortunately,
yes,
a lot of the findings were very muddled, and we were not able to finally find out first of all, why is this patient jaundiced? And we are not able to find out what is this actually the mass that you are feeling. At least you didn't give us the impression that you are not sure about what was the mass that you were feeling. So this patient, unfortunately, now with a mass that is this large and obstructive jaundice, we have to do an MRCP to find out what is the cause for the obstructive jaundice, and then we have to attempt to palliate his jaundice, because surgically no other treatment can be given, and because the patient is in pain, we have to palliate the pain and keep the patient comfortable. Dr. Arjunan, you want to give us
Ravi, but here,
yeah.
See, people also have to understand that liver failure.
In this case, both the CA19 and AFP are elevated. So this is more likely to be intrahepatic cholangiocarcinoma, which has caused the kind of liver enlargement as in this case.
Correct.
And as you can see, both lobes of liver are enlarged and not amenable for resection as it is. The only point of treatment we can consider in this case is liver transplant. That is all.
Okay, sir. Thank you, sir.
Not amenable for resection.
Yes, sir.
But Dr. Ravi Arjunan,
students also have to understand that there can be liver cell volume may be so less because of the tumor and cholestasis that also can cause jaundice.
Okay, sir.
Yeah.
Okay, sir. Yes, sir. So we'll
just 1 minute, Harish. I have kept quiet throughout the whole presentation.
Yes,
Doctor, with this kind of presentation, I'll evaluate you as 50-50. You're sitting on a fence, and it's likely that if you don't do well on the other sides, you may go down. So please be careful. It is very clear that you are presenting this by knowing the diagnosis and trying to create a story to match it. And that is why you ran into trouble with the examiners. I didn't open my mouth. I just listened. And this is my impression.
yes, sir. Thank you, sir.
So
Thank you.
not 50-50.
Dr. Ravi Arjunan, just for the for the knowledge of the students, even this bigger tumor, is it still amenable for liver transplantation? Because the current guidelines, Milan criteria, the size of this tumor is so big that you may not, it may not fit the criteria. And at 80 years of age, is liver transplant an option?
True. Considering his age, liver transplant may not be an option.
So palliation of pain and palliation of jaundice.
Yes.
That is all we should offer.
That's all.
Yes.
That's all.
Yeah. So we'll move on
please
to
don't go into transplant for this.
Okay, right.
So we'll move on to the next case by Dr. Abhishek from Hubli, KIMS Hubli. Dr. Abhishek?
Just a minute, Dr.
Yes, sir.
Sanyal. Dr. Sanyal, you should.
Yes, sir.
It is good that you made these mistakes on this presentation. Please take the corrections as they are not meant to make you disappointed or make you feel bad. It is these are all positive corrections that you should make to make yourself better in terms of in the final exam. Okay, all the best.
Thank you, sir.
Yeah.
Dr. Abhishek?
Yes, sir.
Yeah, please proceed with your case, Abhishek.
Kindly keep your cameras on, please. We don't want to keep talking to a black screen.
Yeah.
We want to see whom you're talking to.
Correct.
Abhishek,
Yes, sir.
the camera and proceed
The
the
lady, I
presentation,
keep
my
quiet,
dear.
but if it's a gentleman, show yourself, man. Come on, have some guts.
Yes.
Yeah, that's good. Smart guy. Smile, man. Okay, present.
Good evening, everyone. Myself, Abhishek, graduate student from KIMS Hubli. I am presenting a case on soft tissue sarcoma. Here is a 40-year-old male patient.
No. If you have attended the classes for the last 4 days, I think it has been made amply clear that you should not say I'm presenting a case of. So then that is the end of the discussion. There is no need for us to go any further.
Your opening statement itself is wrong.
Wrong. You should not make a statement like that. Okay.
Presenting a case of so-and-so swelling.
Yes.
Soft tissue swelling for
Don't tell the diagnosis. You proceed with the presentation.
Statement itself is wrong.
Start.
Here is a 40-year-old male patient hailing from Hubli, farmer by occupation, came with chief complaints of swelling out the right side of the abdomen since 1 year. Patient noticed the swelling in the right side of the abdomen, initially of size 2 x 2 cm in the upper abdomen, insidious in onset, over a period of 6 months. Swelling was not associated with pain. no history of altered bowel habits, no history of melena, blood in stools, no history of weight loss or loss of appetite, no history of jaundice, no history of burning micturition, increased frequency of micturition or hematuria, no history of trauma, no history of fever, cough or breathlessness. Coming to past history, is not a known case of diabetic mellitus, hypertension, tuberculosis, epilepsy, or asthma. There is no previous history of radiation exposure. Coming to family history, there is no history of any malignancy in the family. His diet is mixed, appetite is good, sleep is not disturbed, bowel and bladder habits are regular.
Okay, summarize your history.
Sir, middle-aged male patient came with complaints of progressive mass per abdomen in the right side of the abdomen, sir, with no other significant complaints, no other bowel habit.
Okay, Dr. Pai, you want to ask any further questions?
Is a patient with only, he complained about the mass abdomen, isn't it?
Yes, sir.
And there was no symptoms.
There was no symptoms except for mass.
Yeah. So what are those masses which have no other symptoms? Which are those masses which present with no symptoms at all? They present just as a mass abdomen.
Sir, usually any mass arising from parietal wall.
Parietal wall, then.
And then mass which arises from extraluminal bowel pathology.
You mean just gastrointestinal stromal tumors?
It can present with asymptomatic
mass abdomen. Then. Very common in our place here. In Hubli, Dayanad, Bellary area.
You have a dog, man?
Sir?
You have a dog?
Hydrated cyst of,
Hydrated
cyst of liver.
Anything else?
Sir, Dr. Pai sir, ನೀವೇ ಹೇಳ್ಬಿಡಿ.
Soft tissue sarcoma, retroperitoneal tumor,
yes,
hydrated
tumors.
Yes. Benign tumors, albeit rare, of the liver, pseudocyst of the pancreas, but they'll have symptoms, isn't it? They would have had earlier symptoms. Okay.
Previous episode.
One question.
One comment.
Yes, sir.
No history of malignancy in the family. I mean, you should be able to specify what exactly you're looking for. Not all malignancies are familial or inherited. So if you're looking at colonic tumor, you must say no colonic.
Not colonic, sir. Usually in some
I'm just saying, if you talk of history of malignancy in the family in a male patient, you should be able to specify which malignancy are we talking about. Okay? Do not make generalized statement.
See, Dr. Srivatsa's point is a refinement from being an undergraduate to a postgraduate. In undergraduate, that is acceptable. For postgraduate, you need to be a bit more specific as to which malignancies you expect to run in the family. Okay.
Yes.
Dr.
Why radiation, man? What's the connection with this kind of mass? You don't have to mention it because it's not relevant over here. Right?
It's not relevant at all. Dr. Arjuna?
In your previous slide, just go back to your previous slide, please. Just say no history of once and just put down all the factors. Don't keep saying no history, no history, no history. It irritates the examiners. I get ear pain. Yeah. So please say only once. No history of 1, 2, 3, 4, 5, 6, 7, whatever you want to say. Please. All right. It's a better form of presentation and you save time also. Thank you.
And the most important fact that you have said there is no history of radiation exposure
shows that you are not
points to the fact that you are biased in your history. So unless there is some past history of having undergone radiation exposure, you mentioned it. Otherwise, no previous history of radiation exposure, that itself suggests that your diagnosis will be biased. Your thinking is biased. As you made the opening statement itself, that's a soft tissue sarcoma. So these kind of mistakes, simple, silly mistakes, please don't commit. That's
Can I put it in another way? If the patient says he has been radiated, then only tell it.
Yes, that's exactly my point.
Leave it out.
Okay. Hello. So that the students, please note your purpose of presenting in this forum and in the examination is to pass the exam. And if you irritate the examiner, you are unlikely to pass the exam. So try and irritate the examiner the least as much as possible. Okay.
Abhishek, I will
Next.
disagree with Ravi Shankar, sir. It is 3 years of work which helps you to pass in the exam. The exam is just an end. It is not the mean. It's
correct. No. But the presentation in these fora is to prepare for the exam. That's all I meant.
That's also true. That's also true.
Yeah. Okay. Continue.
Ravi,
Yeah, please move on. Don't waste time. Please.
Ravi.
Yeah.
Students must understand that swelling is not the word used for mass abdomen. Okay, so they let them use the word mass abdomen in the presentation.
Okay.
All right.
Continue.
Yes, sir. Coming to general physical examination, middle-aged male patient, moderately built and nourished, conscious and oriented. His vitals are pulse rate 84 beats per minute measured in right radial artery. Blood pressure is 130 by 80.
Is there anything positive in the general physical examination?
No, sir.
Okay. Move on to the local examination.
In all forms of malignant cases, please mention Karnofsky scale and BMI. Okay, calculate and give it. Thank you. Next, continue.
Coming to per abdomen examination, inspect mass noted in the right side of the abdomen of size 30 cross 20 centimeter. All borders are well made out, with superior border approximately 10 centimeter below the nipple in mid-clavicular line and inferiorly extending 5 centimeters above the anterior superior iliac spine, medially lateral to the midline and laterally extending till mid-axillary line.
Carry on.
Excellent. Surface of touched and shiny with vein over the swelling, no scar or sinus, no visible pulsation or peristalsis seen. On head raising and leg raising, mass becomes more prominent. Area is normal and renal angle, no fullness in the renal angle. Coming palpation, inspectory findings are confirmed. Mass of size 30 cross 20 cross 10 centimeter in the right side of the abdomen with well-defined borders. Upper border is at the level of 6th rib in midclavicular line. Lower border extending till 5 centimeter above the level of ASIS, anterosuperior iliac spine. Medially 2 centimeter to the right of midline. Laterally up to the mid-axillary line with bosselated surface. Mass is firm to hard in consistency, mobile both horizontally and vertically. No local rise of temperature, non-tender. Rest of the abdomen is soft, non-tender. On raising and head raising, the mobility becomes more restricted. Sir.
Okay, continue.
Abhishek,
yes, sir.
You mentioned right side of the abdomen.
Yes, sir.
So in addition, it would be better if you mention the quadrants, which are on the quadrants it is occupying. You have just mentioned vaguely right side of the abdomen. So on palpation, it would be better for you to mention which are all the quadrants of the abdomen it is occupying. So that will give a better picture to the examiner and it will be a better way of presenting. Okay.
Abhishek,
yes, sir.
Just a request. Can you go back to your previous slide?
Sir.
Can I just about the mobility? That's all. Mobility. Sir. Can you just tell again?
Sir, it is in vertically out and on leg head raising that's restricted, sir.
Thank you.
One more thing, the upper border is
yes,
at
sir.
the level of 6th rib.
Yes, sir.
Are we talking about the surface of the rib? On the surface of the rib.
Sir, it is extending till the 6th rib, sir.
That is what? On the surface of the rib. We are not going under the rib here.
Yes, sir. Over the surface of the ribs.
Okay.
Yeah, please proceed.
Yeah,
please.
Proceed.
Any other findings?
Sir, no other significant findings. Sir.
What other significant finding you were expecting?
Looking for.
Specifically.
No other organomegaly.
No evidence of ascites. Just said he doesn't like organomegaly.
Abhishek, you also missed out on percussion over the abdomen. You have said no free fluid. You go back to the slide, percussion.
I think the most important thing when I mentioned the 6th rib was, did he mention the plane of the swelling? Go back to the previous slide.
He said, you said it is in which plane? You didn't mention the plane. But you
exactly.
gave us the findings.
That is the reason I asked him.
Gave us the findings.
Sir?
What is the plane of the swelling?
Sir, since on leg raising and head raising, mass becomes more prominent and mobility becomes restricted, it is rising from parietal wall, sir. Extra abdomen.
That is the most important thing, in your examination.
You have not mentioned that.
You should mention, no? Is it that's the most important point in the
He has mentioned the
findings.
finding, he's not given the interpretation.
Correct.
I don't blame
Correct.
him. Let us see if he comes out with it in the diagnosis.
Okay.
No, but he didn't give the finding of the mass becoming
did, he
more
did.
prominent on.
He did that. He
Yes,
did that.
he did.
Okay. Okay. Right. What else? What are the findings? You know, you said no other findings. What specifically were you mentioning?
Looking for.
You know, a swelling of this size, you know, affecting the parietal wall, as you said. So, what other things you would look for?
Abhishek, please go back to the previous slide.
Something in the groin, axilla.
It's not mentioned where he put the muscles into contraction.
Sir,
See, on
on,
palpation also, you have to do the head raising and leg raising
yes, sir. On head raising and leg raising, mass becomes more prominent.
test
No,
and
the
check for mobility,
palpation.
no? Before
Palpation.
contraction of the muscles and after contracting the muscles. Have you done that?
Yes, sir.
What happens?
Sir, mobility becomes restricted, sir,
Okay,
on contraction.
all right.
He has
And it becomes
mentioned
more
it.
prominent.
Let's move on. Can we move on, please?
So you should.
We've got lots to discuss.
You should mention about the lymphadenopathy. Isn't that not right?
Sir, since
Yeah.
huge mass arising from parietal wall, it's less likely to metastasize to lymph nodes, lymphatic spread. But
Right.
there are no
No.
lymph nodes.
No,
sir.
no, no.
See,
No,
see, you
that's
are-
not a reason. You have to examine lymph nodes of any mass from the abdominal wall. We'll ask you the reason later, but you have to look for it. And
Yes,
this
sir.
borders both axilla and groin. If
Groin.
you don't
You have
mention
to
that, it's a
mention
big
that.
negative.
And not supraclavicular. I mean, axilla, groin.
I told
Axilla,
you.
groin, very important.
Very
Yes, sir.
important.
Pinchability. Skin pinchability also not mentioned.
Again, you cannot keep on giving the impression that you know the diagnosis. You are trying to fit in your findings to that. You have to present it as if you don't know anything about it, and you make a methodical, you know, synthesis of the findings and come to a diagnosis. So
Yes, sir.
please don't give us the impression that you know the diagnosis already.
I think here
Yes.
clinical examination is extremely important, where he has made a lot of mistakes. Skin pinchability not mentioned, whether it is adherent to the muscle or infiltrating the muscle not mentioned. Plain and the swelling, he did not commit.
Abhishek,
Yes, sir.
is it pinchable? Is the skin pinchable over it?
Sir, skin is
Sir,
pinchable
infiltration
all over
is-
the mass, sir, except for the summit of the swelling where biopsy was done, sir. Except there, everywhere it was pinchable, sir.
Okay. And is it infiltrating the muscle, do you think? How do you know whether
Rising
it's
from the
infiltrating or not? How will you know?
What muscles are there? What muscles are you looking at?
Sir, oblique muscles of the
Yeah.
It's
Inter-abdominal wall,
extending
sir.
up to the midline, right? Oblique
Yes, sir.
and
Rectus.
oblique
And rectus muscle.
recti
Rectus, sir.
muscle. So how do you
So-
put that in contraction?
So what happens if let us say if there is infiltration of the muscle, what are the findings?
So first thing is I want to know how it's not head rising test or leg rising test. That is wrong. Oblique muscles are best put into contraction by Valsalva maneuver. Rectus
Yes, sir.
muscle put into contraction by leg rising, head rising.
Yes, sir.
So if the mobility of the swelling is initially there, and then if you put the muscles into contraction and the mobility is restricted, that indicates that this is
It's arising from that
it also indicates the
arising
place
from that muscle.
and possibility that it may be infiltrating the muscle as well.
Yes, sir.
Okay. So any other things that you look for? You said,
Doctor, can we move to some management, please? This is
Yeah.
interesting. There's lots
Yeah.
to share with them.
Okay. Chest examination clinically, is there anything you want to say?
Sir, chest examination on chest examination bilateral hereditary is equal, sir.
Not
And no
that.
added, sir.
What would you expect? The only thing you would expect in clinical examination?
Effusion, sir.
Pleural effusion. Okay. How do you investigate this patient?
No, he has
Rajan, he has already made a diagnosis.
not told
in
his
the beginning.
diagnosis. What's your
He
Yeah,
diagnosis?
started with the diagnosis. So we
Yeah.
are grilling him on examination because this is where they go wrong with a massive mass. This is where they go wrong.
Okay. So the other thing you forgot to mention was the prominent veins over the mass.
That you have mentioned.
Mentioned it, sir.
Okay. Okay. Right. Now, how will you investigate this patient? What is your clinical impression? Abhishek.
Sir, rapidly progressive mass arising from parietal wall. The swelling is parietal wall, sir, arising from or probably infiltrating the anterior-abdominal wall muscle, sir. I would like to think in terms of soft tissues tumor arising from the anterior-abdominal wall muscles.
Okay. So what is it called? Soft tissue tumor arising from the anterior abdominal wall muscles.
Sir, soft tissue sarcoma of the.
No, it's called a different name, no? Soft tissue sarcoma is a general.
Rhabdomyoid sarcoma.
Correct. Rhabdomyoid sarcoma. Okay. How will you investigate this?
Any other possibility, differential diagnosis? In soft tissue, any other different, like rhabdomyoid is one, okay, fine. Then.
Sir, liposarcoma. Yes.
Desmoid, though huge size is, that it should be more medial over the rectus muscle, rectus sheath, but still you can get desmoids elsewhere. Even intra-abdominal desmoids are known.
In fact, desmoids will give you more reason for it being asymptomatic.
Abhishek, it would be prudent on your part to give the diagnosis as a soft tissue tumor, probably a sarcoma. And you cannot give the differentiating type of sarcoma, whether it's a rhabdomyoid sarcoma or a liposarcoma or a leiomyosarcoma. We do not know.
Yeah.
So
Correct.
clinically, we have to give a diagnosis as only a soft tissue tumor, probably a sarcoma, soft tissue sarcoma. That is all.
Yes, sir.
At the clinical diagnosis level, please stick on only to this.
Yeah.
Don't give the differential diagnosis unless the examiner asks you what are the possibilities. Then you can tell. It could be RMS, it could be DFSP, dermatofibrosarcoma protuberans, it could be desmoid tumor, so on and so forth. But your initial diagnosis should be a soft tissue tumor, probably a sarcoma. That is it.
Yeah.
Okay.
Yeah, we are probing
Yes,
further because we want to know his knowledge.
Right. So how will you investigate and manage this patient?
Proceed.
Sir, I'd like to get one CCT of the abdomen and pelvis, sir. Since it's arising from trunk, CCT is better for the investigation, sir, for further evaluation, radiological confirmation, and then proceed to histological evaluation, confirmation of the mass.
Okay. So what are the things?
Upside down, man.
What are the things on
No.
CCT?
Isn't that
What are
CT
the-
upside down?
What are the things in CCT?
It's know the plane of the swelling, origin of the swelling, from where it's
Correct.
arising, and extent of the swelling,
Correct.
and if there is any intra-abdominal extension or
Yes. Infiltration.
and to know the vascularity of the tumor, sir,
Correct.
and to look for
Metastatic deposits. Yes.
metastasis, sir.
Yeah.
Good. Yes.
Very good.
So
And what
basically,
else?
you'll come to know the location, size of the tumor, plane of the swelling, whether it's arising from the subcutaneous plane or muscle, parietal muscles, or whether it is going extending down into the intra-abdominal area. All these.
Component abdomen.
Good.
Very
Proceed.
good.
Sir,
Yeah. Just give us the
Fatigue.
salient features in the CCT. What are the CCT show?
sir, muscle arising from mass arising from internal oblique and external oblique, sir. The plane could not be separated between both obliques, and it was not infiltrating into transverse abdominis, sir, muscle. It was only infiltrating both the oblique muscles, external oblique and internal oblique, sir.
Okay.
No intra-abdominal extension, and there was no regional mets or distant mets.
Okay. Okay.
We are left with 5 minutes, sir.
Okay.
This is not case.
How will you confirm the diagnosis?
Sir, I would like to get core needle biopsy, sir. Core needle biopsy from the tumor.
See, core needle biopsy, would you do it, though it is a big mass that is there, would you like the help of an ultrasound, or you can do it confidently without the help of ultrasound?
Sir, since in CCT it was isodence lesions.
Okay. What is the
The
vascularity?
guidance of ultrasound, sir. It's a huge mass. So there was no.
See, the only problem, if at all, if you have to do the open biopsy blindly, is if it's a very vascular tumor. But the CCT will give you the information, and then you can proceed with either an ultrasound guided or a standard, look at biopsy. Okay, core needle biopsy. How will you approach this patient surgically?
I think in the core needle biopsy, what other information should he be getting apart from the histology?
How do you grade tumors, man? What is it? What's the additional information? I've
Will you
given
get the
hint.
grade? Will you get a grade of the tumor?
Sir,
on the, yeah.
Based on the number of metastasis, sir.
Not metastasis.
No.
Mitosis.
Yes, sir.
The
grade of tumors, sir, depending on the number of mitosis and differentiation of the tumor.
For high power field, you will get it as well differentiated.
Differentiated.
It's a high grade, low grade.
High grade, low grade. Yeah.
How do you stage it? How do you stage it? In fact, there are other methods of scoring also. There are 3 components of scoring of soft tissue sarcoma. One is the grading, second is differentiation, and third is presence or absence of necrosis. You put
Yes,
all of them together and you get a number.
Yes, sir.
Dr. Arjunan, please enlighten us on the.
Yeah, basically we get to, by doing a core needle biopsy is the standard of investigation that has to be done for any soft tissue tumor, especially for sarcomas. You get to know the histopathology, number 1, what type, where it is arising from, whether it's a liposarcoma or a rhabdomyosarcoma. Commonest is malignant fibrohistiocytoma in the trunk and extremities. So these things you'll get to know. Number 2, as Dr. Srivatsa told, you'll get to know the grade. How do you get to know the grade, whether it's poorly differentiated or well differentiated, is by making out the mitotic count per high power field. The less the number of mitotic count per high power field, it is considered as low grade. More than 15 to 20 mitosis per high power field, it is considered as high grade. And the relevance of this is, if it is high grade, the prognosis is poor. The potential for metastasis is more to the lungs. And thereby the treatment, whatever you give, is going to be only for the local control. High grade indicates poor prognosis.
Yeah.
Basically, you may have to add adjuvant radiotherapy or adjuvant chemotherapy. So these are all the advantages of getting the tumor differentiation, whether it's low grade or high grade, and what type of tumor it is, whether it is a leiomyosarcoma or a rhabdomyosarcoma, etc.
Okay, right. Now, surgically, Abhishek, what would you do?
Yes, sir.
How much margins would you like to give? And what about the depth?
Ravi Shankar, would you do a chest CT?
I think we need to do a metastatic workup. Chest CT, definitely. Abhishek?
Yes, sir.
Always in any malignancy, solid tumors, please remember the steps of investigation would be for diagnosis and staging and then treatment. The staging dictates the treatment in any solid tumors or for any malignancy. So always the one set of investigations will be for diagnosis. For example, core needle biopsy will be for diagnosis. Then you will have to get the staging investigations. For example, in this case, you will have to get a CECT chest. Like that for any carcinoma, even breast carcinoma. Diagnosis, you have to do one set of investigations like mammography and core needle biopsy. And for staging, you will have to do either chest X-ray ultrasound or CECT chest and this thing. So this set of investigations you should be having at the back of your mind. One set of investigations for diagnosis and one set of investigations for staging. Please keep it at the back of your mind. It will be easy for your presentation.
Okay.
Staging. He has not committed on staging.
So
Yes,
what
Abhishek.
staging you will do in this case, Abhishek?
Yes.
What is the commonest spread in soft tissue sarcomas? Where does it commonly spread?
Lymphatic spread, sir.
No. You just now said I will not evaluate lymph nodes because
you in the
No, sir.
presentation you said you will not evaluate axillary nodes and inguinal nodes.
Yes, sir.
What are those sarcomas which spread to lymph nodes?
Heterogeneous.
Abhishek?
There are specific sarcomas which spread through lymph
I'm
nodes.
waiting for you to scream out that answer.
Give the mnemonic.
Mnemonic.
That's enough.
Give me the mnemonic just now. Scream mnemonic.
Scream.
Yeah.
Yes. Races. Scream.
Scream, races.
Races. Both are there.
Scare, races, and scream. All three you can.
Yes, sir. So please summarize
Dr.
the
Rajan,
surgical
yeah.
management. So
Abhishek, one more point I would like to add. In the AJCC 7th edition, the regional lymph node metastasis in soft tissue sarcomas was considered as stage 3. Now, currently, according to the AJCC 8th edition, the regional lymph node metastasis in soft tissue sarcomas, that is N1, is considered as distant metastasis and is stage grouped as stage 4. Please remember that. Now, according to AJCC 8th edition, even if there is regional nodal metastasis, it is considered as stage 4. Please remember that.
So, Dr. Arjunan, can you please summarize the management of this patient?
Yeah, let him answer first one. We will see what he gets to. What treatment you like to give, Abhishek?
Sir, I would like to treat medically and then follow.
See, in this patient, you will have to counsel the patient regarding the large tumor size, where then we will have to assess for, as you have rightly put it there, we'll have to do a wide local excision and also reconstruction either with mesh or with soft tissue transfer. Thereafter, you may require to give adjuvant radiotherapy in this case. So that will be the line of treatment in this case.
Sir,
Yes,
Dr. Ravi Arjunan, sir.
Yeah.
Because he said, according to the CT, the internal oblique and external oblique was involved, but not the transverses. You have to go one level below, so you have to take out the transverses as
Exactly.
well. Yeah.
Abhishek, any role for
the depth of the third dimension would include the 1 centimeter margin of the depth also will be included. Basically, the margin that should be given is 1 centimeter all around, and the depth also should be one centimeter, so that you get a good oncological clearance.
Correct.
I see the skin is also incised, not excised.
Yes, sir. Thank you, sir. It's a time up. Thank you, Dr. Abhishek, for a good presentation. So,
Again,
Rajan sir, anything to say on this performance?
I would not agree to a good presentation. Again, it's very clear he knew the diagnosis. He also is sitting on fence 50-50. In fact, on the just failed side. So he has to pick up.
Okay.
Yeah.
This is my assessment for the
Okay,
benefit of the student to improve. Not that I have anything against him.
Yes.
Sure.
Yeah. Thank you.
I move on to the next case by Dr. Nihal from MSRMC Medical College. Dr. Nihal, Sharath, please share the slide, please.
I wouldn't be commenting on Nihal's presentation because I come from MSRMC, so I would be keeping mum.
Okay.
No, sir, I know
Sharath?
you are impartial, so we don't have to any worry about your impartiality.
But I don't know.
No, actually, you'll be more severe on your students, I think. Okay, start, Dr. Nihal.
Sharath.
Jo bole so Nihal, Sat Sri Akal.
Yeah, good evening, sir.
Yeah.
Good evening, respected faculty and my dear friends. Today I'll be presenting the case of presenting a 60-year-old male who comes with who is hailing from rural Bangalore, who is coming with the chief complaints of pain abdomen in the right side of the abdomen since 1 month. Patient has a pain on the right side of his mid abdomen since 1 month, which was sudden in onset. It was progressive in nature, involving the right lower abdomen over the course of 1 month. It was colicky in nature, continuous, it was non-radiating, and was only relieved on taking IV analgesics. However, there are no aggravating factors. He has no history of vomiting or hematemesis, loss of appetite, or loss of weight. There's no history of constitutional symptoms such as evening rise of temperature or night sweats or loss of weight. There's no recent alteration of bowel habits. There's no constipation, diarrhea, or any bleeding per rectum, and there's no history of hematuria. Coming to the past history, the patient had no similar complaints in the past of any pain abdomen. not any previous abdominal surgeries. He is a known case of diabetes mellitus since 12 years on oral hypoglycemic agents. Among the family, there was no history of similar complaints in the family of any mass in the abdomen or any pain abdomen, and there's no history of familial malignancies such as gastrointestinal malignancies. In the personal history, he has a normal appetite. Sleep is not disturbed due to the pain, normal bowel and bladder habits, and he has a history of tobacco chewing since the last 40 years. However, he's a non-smoker or a non-alcoholic. Come to the brief summary of the case. We have a 60-year-old male with 1 month, which has progressed to involve analgesics. However, there is no other relieving participant.
Okay. Doctor, don't you think your history is slightly paradoxical because you say it's colicky, but it's continuous? How is that possible?
Very basic point I was going to bring up. Colicky pains is intermittent, spasmodic type. Continuous pains suggest something else. So these two cannot go together, okay?
Yes, sir.
Yeah. Move on. What do you have now? Findings.
So what are the things that go through your mind when you get a history like this? What is likely going on in the patient?
So he's saying a pain abdomen since 1 month, which was sudden in onset. It is mostly only based on the history. I can think of an inflammatory condition of the nature. Since he's not giving a prolonged history of only 1 month history of acute pain abdomen, which has progressed to involve the right lower abdomen, with no other history of complaints of bowel or bladder disturbances.
Yeah. Okay. That's fair. Okay. Go with the examination. Anything, Dr. Ravi Arjunan?
No, nothing. You can proceed.
Okay. Proceed.
Coming to the examination, a moderately built and nourished individual who was conscious and oriented time, place, and person with an ECOG score of 0 and a BMI of 21.5. His vitals, he had a pulse rate of 82 beats per minute measured in the right radial artery with good volume, a blood pressure of 130 by 70 millimeters of mercury measured in the right brachial artery in the supine position, and a respiratory rate of 17 cycles per minute. He has no pallor, icterus, clubbing, cyanosis, or generalized lymphadenopathy or pitting pedal edema as noted. And the patient was examined in a well-lit room with adequate exposure from mid-thigh up to the nipple. And on inspection, we can see on inspection, the abdomen appears distended. There is a mass noted, an ovoid mass noted in the right lumbar region, right iliac fossa, which is around 10 into 15 centimeters, which is extending up to the umbilicus and laterally extending up to the anterior axillary line. Inferiorly, it is around 2 centimeters above the anterior superior iliac spine or around 8 centimeters above the pubic symphysis in the midline. And superiorly, it is around 10 centimeters from the right costal margin in the midclavicular line. There is no visible peristalsis or scars, sinuses, or dilated veins noted over the mass. Bilateral renal angles appear free. The external genitalia is normal, and there's no cough impulse. The external hernial orifices are also normal. There's no cough impulse noted. Coming to the palpation, tenderness was noted over the mass, which was a 15 into 10 centimeters mass in the greatest horizontal and vertical dimension in the right lumbar region extending up to umbilicus and right iliac fossa region. The superior border was felt 10 centimeters below the right costal margin in the midclavicular line, inferiorly 2 centimeters from the anterior superior iliac spine or around 8 centimeters from the pubic symphysis in the midline, laterally extending up to the anterior axillary line and medially up to the umbilicus. It has a smooth surface, which is firm in consistency, and the skin over the swelling was pinchable. It is non-mobile or palatable. It does not move with respiration. And on a leg raising test, the mass becomes less prominent. Hence, it is intra-abdominal. There is no hepatosplenomegaly or no other masses felt over the abdomen. There is no renal angle tenderness. On percussion, there is a normal liver span of 11 centimeters. There is no shifting dullness, and there is no change in note of the on percussion over the swelling. On auscultation, there is normal bowel sounds, and on rectal examination, there is no mass noted in the rectum or no Blumer-Shelf nodules felt in the rectal examination. System examination is normal with S1, S2. Yes.
Okay. Dr. Arjunan, any questions?
Your presentation is very good about the mass. Nicely, you have described the mass. So can you go on to describe what is your anatomical diagnosis and what is your pathological diagnosis?
So coming to the anatomical diagnosis, based on my examination, my clinical examination, since the mass was not mobile, it was not mobile, and there was no, it was not moving on respiration either. I would like to think, firstly, I'd like to think the origin as retroperitoneal nature.
You said the mass is tender on palpation. Will a sarcoma be tender on palpation?
No, sir, it will not be tender.
The very fact that it is a tender mass and short
history, you said inflammatory mass, which is probably
duration, I will not consider my first diagnosis. I will not accept as retroperitoneal sarcoma at all.
Okay, sir.
Dr. Pai?
Sir, a few questions. Number one to the candidate. Could you put your slide on your palpatory findings, Nihal?
Yes, sir.
Yeah. Now, whenever you're making why did you look for movement with respiration? Once your renal angles were free, why did you look for a movement with respiration for a mass which is 10 centimeters below the right costal margin in the midclavicular line, whose left border is right border is up to the anterior axillary line? Still, you look for movement with respiration. Why?
I was still thinking of the renal mass, like the origin.
Doesn't matter what renal mass, but your renal angles were free, right?
Yes, yes, it was.
Renal angles were empty.
Yes.
That was your finding, number one. Still, you look for movement with respiration?
No, sir. Since the swelling is, since the mass is quite below the costal margin, below the diaphragm, it's not important in this, sir.
Actually, it's counterproductive to look for it. Means you're not really understood. Okay.
Yes. Yes.
Second thing, you try to move the mass.
It was not mobile, sir.
It was not mobile.
Horizontal or the vertical directions.
What is the surface?
Surface, it had a smooth surface, sir.
What about the peripheral pulses on the right side, on the right lower limb? The
lower limb pulses were felt, sir.
Nerve examination of the right side. Have you mentioned?
I have not.
Sensory on the right side.
Not mentioned, sir. I have not mentioned.
Yeah. Why we would ask that? You think?
A large pelvic mass, if it a large pelvic mass.
The mass is fixed, isn't it?
Yes, sir.
Okay. The mass is fixed. You're finding, correct?
Yes, sir.
Should you examine the nerves, motor and sensory?
Yes, sir. For nerve compression, if it's a large pelvic mass.
Yes. Compression or involvement?
Involvement, sir.
Okay. Why do you examine the artery, peripheral pulses on the right side?
So there's a mass compressing or involving the iliac arteries. It can cause a depression in the peripheral pulses. It can also present as a large enough mass indenting on the inferior vena cava can cause peripheral edema also.
See the mass pressing on the artery.
Reason?
Mass pressing on the artery. You know, what is the pressure in the artery? 120 millimeters. No mass will be able to overcome that. So there will be not unless it is completely infiltrating or encasing the artery, you will not get a reduction in the pulse. So, yes. But your point about venous compression is well taken, but not the compression of the artery, because artery's pressure is 120 millimeters. You can't press and reduce the pressure by external pressure, unless it is infiltrating and encasing, just like it happens occasionally with the carotid tube, the carotids with thyroid.
Yes.
It will not, the volume of the pulse will not be affected by that. I think that's wrong. See, you should always give the impression that you know things. Okay, Dr. Rajan sir, anything to add to the clinical examination?
I was waiting to catch him on the distal pressure effects. Dr. Srinivas has already done it. Please remember, anything involving the midline, especially at the umbilicus and below, distal peripheral pulses, and for edema, neurological examinations are all important.
Yeah. Yes, sir.
There's something called do not forget. So you must, in the things that you must not forget is the faraway effects of a mass in the abdomen. So just remember that.
Yes, sir.
Okay, so if there are no other questions on clinical findings, Dr. Arjunan, would you like to proceed with the differential diagnosis?
Yeah, would you like to consider a renal mass, Nihal?
The patient, actually it was in my mind, sir, initially, but the patient did not give any history of any urinary complaints of hematuria or pyuria or urgency or frequency, or neither did he complain of, he did not notice the mass in the right iliac fossa region either. His main complaint was pain abdomen, which he had come for. Even on the examination.
Just a minute, Nihal.
Yes, sir.
Where do renal masses arise? I mean, where would the mass be?
We mostly in the right lumbar region, sir.
What do they present with renal masses? First, what will be the first symptom before hematuria and other symptoms, before urinary symptoms?
Fever, sir. Low-grade fever.
That is paraneoplastic syndrome. If it is there, it is unlike, it is one of the 16 odd symptoms, paraneoplastic. What is the commonest symptom which the patient will have? In the costovertebral angle, something they'll have.
Costovertebral pain.
Why they should have a costovertebral pain? Because of stretching of the renal capsule, the tumor. It will be a continuous pain, right?
Yes.
Your pain here is colicky continuous, because you have to make sure what it is.
Yes.
Is it colicky continuous or dull aching continuous? What is it?
He said colicky continuous.
No, do you want to give a solid organ with the colicky pain? If your diagnosis, what is the requisition to produce?
Srinivas,
yes, ma'am. Yes, sir.
We have come out with what the patient mentioned.
Yeah,
this is what I'm trying to say. Interpret what the patient says. Transcribe it.
Yes.
So Nihal, other thing is, there is a question in the box, about renal, symptoms like hematuria and things. Those are very late symptoms in patients with renal masses. So as Dr. Pai said, pain is probably the predominant symptom early in the illness. Only very late you can have hematuria and other symptoms.
I think you should be talking about clinical examination, which does not suggest renal mass.
Yeah, that too.
Yeah.
Yes. On the clinical examination, it is the mass was not ballottable or bimanually palpable, and on percussion of the percussion laterally to the erector spinae muscle at the renal angle, there was a resonant note noted on percussion.
Dr. Kanagavel, sir?
I think I've been closely following this. I'd like to ask the student, what is the probability of a potential colonic pathology presenting like this?
So a mass of such a big mass, he would definitely have features of obstruction, sir. So I feel it is not.
Especially when you have such a mass and without obstructive symptoms?
Yes, I'd not like to think as colonic or intramural. Maybe an extramural cause, maybe
like potentially
just
possible pathology.
A gastrointestinal stromal tumor, sir.
Okay, that should be kept under consideration because all the faculty have been not immediately agreeing to the diagnosis of sarcoma. So that also has to be kept under consideration. How do you explain pain as the component? Because I'm sure both Dr. Ravi Arjunan and Dr. Abhishek was highlighting the point of pain component.
Retroperitoneal sarcoma with areas of hemorrhage, they can have.
So that should be the potential possibility. And number two, compressing on the nerves, because both of them very clearly highlighted the vascular encasement or infiltration comes at a much later point. External compression of the nerve also could be a reason for the pain. But Dr. Pai was very clearly asking whether there was any distal neurovascular involvement.
Dayanad has rightly pointed out. Nihal,
yes, sir.
You presented in your own history that the patient had colicky pain, is it not?
Yes, sir.
So, as Dr. Gnanavel has rightly pointed out, colonic mass should be one of your differential diagnoses.
Yeah.
If not arising intraluminally, it should be probably extraluminal, causing partial obstruction. At this point of time, he may not be having obstruction. So, in this case, you cannot pinpoint.
Perfectly said, sir. I think we need some
more like a retroperitoneal sarcoma. It will not be accepted. It will not be accepted at all. So you have to be prepared with one differential diagnosis depending on the location of the tumor, quadrants involved, and depending on the history. Also, you'll have to correlate all these and try to give a few differential diagnoses.
Perfect.
So can you revise your diagnosis now His retroperitoneal sarcoma will be last in my consideration. So can you give a differential diagnosis based on the history and findings, which can fit this particular case?
Maybe a gastrointestinal tumor, mostly from the extramural involvement by using a gastrointestinal tumor.
Yeah, you can say probably ascending colon mass. Yes, agreed. Number 2.
Last diagnosis.
Doctor.
Because of the location of the mass, how there are no symptoms. Carcinoma of the cecum.
See, this mass is already abutting to the anteroabdominal wall. Okay. Yes. So the ballotability point of it cannot be commented on whenever the mass is abutting on the anteroabdominal wall.
Yes.
So there may not be ballotability, still it can be a renal mass. So one of your second differential diagnosis should be a renal mass, considering it location, right lumbar mass.
Yes.
Okay. And the third possibility and third of the differential diagnosis that I would like to consider would be a retroperitoneal sarcoma. This should be your order of presentation of the DDs in this case. You cannot pinpoint to one diagnosis.
Yes, sir.
Okay.
Dr. Arjun, I would not agree to a renal mass in this patient, not by my palpable. I mean, I would not put it as maybe a last diagnosis, but I would still agree. Yeah, if it's a colonic, it could be either a lymphoma,
one of the DDs,
joint lymphoma, or a GIST, which is rare in a colon. GIST is less than 5% of all GI GIST. So lymphoma, if you think of colonic, and then second, yes, retroperitoneal sarcoma, and maybe a renal.
Yes.
Okay.
This is where the internal examiner comes in to help the candidate. Very good.
Yeah.
But remember, candidate, you won't have an internal examiner. If you go into the DNB sites, you have 4 strangers at you. So be careful.
Okay. How will you investigate this patient?
I'd like to investigations to confirm my diagnosis and to give me stage and plan my management.
Okay.
To confirm my diagnosis, I'd like to first get an ultrasound of the abdomen and pelvis.
Yeah.
An ultrasound of the abdomen pelvis to confirm the origin of the disease, origin of the mass, to check for areas of if it's a heterogeneous or a homogeneous mass with areas of hypertenating areas.
See, the ultrasound is a good point to start, but when you're thinking about it being from the bowel origin, I think ultrasound doesn't actually.
It won't.
Not a very good investigation, but it will give you information in terms of what is the status of the liver, presence of ascites, presence of nodes, possibility, and all these kind of things. So you should mention those things quickly and then move on to the more definitive investigation. What do you say, Dr. Kanagavel, sir?
I agree with that, sir, but I think for that limited time, let us move on to the specifics for this patient.
Specific investigation.
We have another 20 minutes, so let the candidate go for the specific investigation.
I would like to get a contrast enhanced CT scan of the abdomen and pelvis.
Yeah.
With a oral contrast and a rectal contrast also.
Sure. Okay. What are the information that you are likely to get on the CT?
On the CT, one will get the size of the mass. If there are any, if it is a heterogeneous or a homogeneous mass.
Correct.
Third, the origin of the mass.
Yeah.
And if there is presence of
size,
yes,
extension,
yes,
infiltration. What else?
Yes. If there is any lymph node,
correct. Metastasis, lymph node, liver.
Local metastasis, signs of lymph nodes, and if there is, that's also.
Okay. So can you read this CT scan and tell us what is going on?
So the CT scan shows a wide, large. So the wide, large, heterogeneously enhancing mass arising from the jejunum, arising in the right lumbar and umbilical quadrant, measuring 13 into 9.5 to 9 centimeter with multiple non-enhancing areas within the lesion. Lesion is exophytic, probably arising from distal jejunum, involving it for a span of 5.8 centimeters, with mild dilatation of the jejunum measuring 25 mm in diameter. Mild surrounding fat staining is noted. The impression was heterogeneous mass arising from the distal jejunum to consider neoplastic etiology.
If it was a mass arising from jejunum, would you not expect it to be mobile? Why
Yes,
is it
sir.
not mobile?
This was a googly. The
Due
find
to the large size of the
No,
mass,
even given the size, it still would be mobile. But what is the possibility that it is not mobile? I think Dr. Ravi Arjunan already alluded to that. So, Dr. Arjunan, what do you think?
Yeah, exactly, because usually this jejunal mass and all will be quite mobile, either transversely or in a vertical fashion, because they're arising from the jejunum. So the question of why it was not mobile is a bit confounding.
Nihal?
it was not moving.
Yeah, I agree with you, but just explain. We are only looking for logical reasoning.
And the tenderness, how do you explain the tenderness? You said mass is tender.
Yes, sir. It was tender on my question, sir.
Yes, sir.
I could see there are potential. Can you get to the CT slices for a moment, please?
Yeah.
You can see there are variable
Go to the CT picture.
densities.
Nihal, go to the CT picture. CT picture,
No,
please.
previous slide, just previous.
Yeah.
If you could see, there are areas of possible hemorrhage into the mass. Can you appreciate that? That's why Sir asked you to read the CT. If you see, there is
necrosis and hemorrhage.
Correct.
That is the reason for the tenderness.
So you should be able to explain when you read the CT, you describe either it could be a tumor necrosis or a hemorrhage into the tumor, which could both be explaining the potential reason for the pain.
And you can see the infiltration of the abdominal wall.
That is what the mobility answer is explained, because the tumor looks it is involving the transversus abdominis along the lateral abdominal wall.
Which is the
so if you have, please sir, go ahead. Sir.
Yes, sir. No, please.
So the point is, when every examiner was highlighting the importance of mobility, this could be the potential. There is loss of plane on the sides. If you see very clearly, the plane at one segment, at least 2 to 3 centimeters, it looks like it is infiltrating into the transverse abdominis. Maybe in one slice, it is very difficult to comment. If you have multiple slices or a sequential video study of the CT images, you may be able to highlight. So if the examiner is asking in the Viva session, where CTs are also nowadays shown in the afternoon session, you should be able to justify these are the potential reasons for non-mobility of the tumor. That's all from my side, sir. Thank you. Other examiners may take over.
Dr. Arjunan, sir, I think there are also lymph nodes which are there. Did they comment on the lymph nodes?
Yes, few lymph nodes are also seen.
Yeah.
So what would be your probable pathological diagnosis, Nia, in this case?
Ileocecal tuberculosis. Tuberculosis of the...
No,
why
this
tuberculosis
mass is arising from jejunum as per the CT scan. Why did you suddenly jump to ileocecal tuberculosis? It's clear cut the scene. The
tumor.
It's a tumor, man.
Report is that mass is arising from jejunum, mild infiltration of the transverse abdominis muscle with central areas of necrosis and hemorrhage. So what would be your probable
of gastrointestinal stromal tumor only?
Pathological diagnosis.
Gastrointestinal stromal tumor.
Yeah, that is the only possible explanation in this case. Gastrointestinal stromal tumor could be the diagnosis in this case.
Yes.
Okay, now let us. How will you confirm the diagnosis? Will you do a biopsy in this case?
No, sir.
Why not? Why not? We need the histology, no, before you do some surgery.
After we resect and send this case for histopathological examination, that we can stage the disease based on that itself. Sir.
Sure, but other answer we expected from you is GIST tumors are very vascular and it is potentially hazardous due to a biopsy. That is the answer we expected from you. Yes. Would you like to do a colonoscopy in this patient?
Yes, sir.
Why?
To rule out if presence of other adenomas, adenoma sequence in the colon.
No. See, you said it's a GIST tumor. There is no
Yes.
question of adenoma carcinoma here. So colon will be, free. But, and again, I don't think GIST tumors are multicentric in origin. So though, and colonic, as Dr. Srivatsa said, colonic GISTs are quite rare compared to the small bowel.
Yes.
Small bowel is the commonest site of origin of GIST tumors.
Yes.
So I don't think colonoscopy is required because CT scan will
Gastric
have
GIST
given
is the
you-
commonest, counting for 50 to 60%.
Yeah.
Then esophageal GIST is 10%, rectal GIST is 10%,
Yeah.
and then colonic is around less than 5%.
Yeah.
That's the incidence, how it goes.
Yes.
So how will you manage this patient, Nihal? What is the most horrible complication that you are very scared of in this patient? It is a devastating complication. It can be devastating of this size. I already mentioned that to you.
Bowel obstruction, sir.
No, obstruction is not a devastating complication. What are you worried about whenever you operate on somebody? And even hemorrhage.
Hemorrhage.
So, these GIST tumors can bleed so heavily. I have seen patients with hemoglobin of 2 and 3 barely surviving. So it can bleed catastrophically. So that is one thing you have to be worried about.
Yes, sir.
So
What is the surgery you will do for this patient?
The resection anastomosis of the short bowel, sir. Resection of the tumor with the 10 centimeter proximal and distal margin, and anastomosis of the remaining parts.
Why 10 centimeters? Why 10 centimeter margin is my question. If you give 10 centimeter margin proximally, probably you will reach up to the D1 or D2. Then what you will do? You will still go ahead with 10 centimeter margin proximally.
No.
What is the ideal resection margin for a GIST?
Up to 5 centimeters.
2 to 3 centimeters is sufficient on either side. Actually, if it is adenocarcinoma, what you said is right. Proximal and distal should be 5 centimeter margin in order to
It's a vertical spread.
Take care of the submucosal lymphatic spread. Whereas in a GIST, the ideal recommended margin is 2 centimeters is enough on either side. But 5 centimeters would be the ideal recommended margin for adenocarcinomas.
Yes.
So Nihal, what are the prognostic indicators in a GIST tumor?
What is the size of the tumor, sir?
Correct.
Second,
so give us, no, you have to elaborate on that.
Size.
Yeah. Size less than 5 centimeters, 5 to 10 centimeters, and beyond 10 centimeters. So that is the first one thing. Other second prognostic indicator. Do you know or you don't know?
Don't know.
Organ of origin. So if they are arising from small bowel, they have got better prognosis. Ileum, jejunum, they have got better prognosis compared to the ones arising from esophagus, stomach. Probably stomach is probably second in the line, and then coming to the rectum, large bowel, esophagus, they have all got poorer prognosis compared to small bowel. And third thing is as you said, once you excise or resect these tumors and you send them for histology, they will talk about the number of mitotic figures per hyper field. So depending on that, you classify them. So any tumor less than 5 centimeter arising from small bowel has got the best prognosis. Any tumor arising from other organs which are larger than 5 centimeters or 10 centimeters and with higher mitotic indices will have poorer prognosis.
Yes.
And how do you treat them after you have actually resected it?
Can I ask a question here?
Yes, sir.
Yeah. Nihal, does it spread by lymphatics or hematogenous or both?
Spreads mostly by hematogenous, but there is a chance of lymphatic spread also. So.
Lymphatic spread extremely rare, extremely rare.
Dr. Ravi Arjunan, answer to that question.
Hematogenous spread is the commonest in GIST.
Yeah.
Lymphatic spread is very rare, less than 1%. It is not accountable. Main mode of spread is hematogenous in case of GIST, whether it is in the gastric GIST or a small bowel GIST.
Correct.
So do you need a chest X-ray?
Elsewhere, main mode of spread is hematogenous.
Chest X-ray?
Kanakavel, sir.
Nihal, when Dr. Abhishek sir was asking about surgery, as a routine, a candidate is expected to tell the surgery will depend on the operative staging, number one. So make a point, you tell that before you talk about the resection margins and other things. This is number one. And again, as a word of caution, sir was asking about how the tumor spreads and what is the next organ of spread and other things. Actually, your tumor measures 13 centimeters.
Yes.
So 13 centimeters, ideally, as per the guidelines, this patient, if you have a preoperative tissue diagnosis of GIST, qualifies for a downstaging protocol before you jump into resection, right? Because sir very clearly said up till 5 to 10 and above 10. This is definitely a large tumor, which if you have a preoperative diagnosis of GIST, and especially a particular tumor marker, if it is positive, then this qualifies for a downstaging. These are the two things you should keep in mind.
Yes, sir.
So what is the marker if you are talking about GIST in this patient? Because sir was repeatedly asking true cut biopsy, what are the things you look for? What is the immune marker you'll be looking in this case if you are talking about a GIST?
CD 117 and CD 34.
Okay. So if it is CD 117, what will be the potential drug which you would like to use for downstaging, and how long you'll be using that for a reassessment, response assessment?
Imatinib, sir. Imatinib will be used.
No, you should say tyrosine kinase.
Tyrosine kinase.
Yeah, tyrosine kinase inhibitor. That's the right word first. Then you go for the word imatinib.
Yes.
Right. So minimum of how many days?
Not sure about that.
So it depends on the protocol what you are using. So actually, sir said about the mitotic index. So you also talk about the mitotic index of the true cut biopsy. Depending on the mitotic index, depending on the grade, you talk about a minimum of 90 days of usage of imatinib mesylate, right? So then you go for a repeat assessment. See, potentially, please listen. These are all done only when the tumor does not have complication. A small bowel tumor of this size can potentially be having a history of on and off bleed or anemia. Sir was telling about that low hemoglobin status also. If there is a bleed, then you don't wait for downstaging. Otherwise, as per the guidelines, this patient will qualify for a downstaging prior to surgical resection. That's it from my side. Other faculty can.
Yeah, Dr. Srivatsa, sir.
Yeah, it's difficult to get c-kit unless you have histological tissue. So here, unless it is inoperable, there is no need for imatinib. If it is yes, there is metastasis to peritoneum, or it is inoperable, it is infiltrating the muscle, then we downstage. A resectable tumor can be resected, and then the patient can be put on adjuvant therapy.
Yeah, but because here there is suggestion of infiltration of the muscle on the CT. Dr. Pai, sir, what would you do?
I would excise. I would do the laparotomy and excise exactly the margins what Dr. Ravi Arjunan said. Then I would wait because like Dr. Ravi Shankar said, somebody has asked in the chat box, should you take a pre-op biopsy?
No
right?
pre-op biopsy.
Yeah, biopsy so that you can give neoadjuvant tyrosine kinase inhibitor. Once you have it, so whatever sir said, vascularity is an issue via the core biopsy. So I would look to see whether there are signs of metastasis, like somebody had said. And since it's in the jejunum, only fixity appears on that single CT to the anterior abdominal wall. I'll go ahead with resection.
Ravi Arjunan, sir.
So in this case, the CT film shows that upfront it is resectable. Yeah. Except for the fact that in one cut, there is infiltration to the transversus abdominis muscle. So along with the resection part of the jejunum, we can remove a portion of the transversus abdominis muscle to give an oncological margin on the parietal abdominal wall. So that would take care of the oncological margin pertaining to the infiltration. And upfront we can go for resection. In this case, it is a resectable tumor, and do an end-to-end anastomosis.
And then subsequently give TK, tyrosine kinase inhibitor.
Yeah. And then proceed with giving adjuvant imatinib.
So how long do you give? Do you know?
It is controversial. The current recommendations are for adjuvant imatinib to be given for about 2 years.
Minimum.
Minimum of 2 years.
And then follow it up with PET CT. Isn't that
Follow
right?
it up on a regular basis with CT abdomen once in 6 months, and if required, PET CT.
PET CT. Yeah. Okay. Any other questions? There are no other questions in the chat box. Examiners.
He must mention a chest X-ray as a preoperative evaluation.
Always diagnosis is followed by staging. That should be at the back of your mind. In any solid tumor, diagnosis, staging, and then only the staging dictates your treatment.
Yes.
Dr. Pai, there is a lot of confusion about staging, even for breast cancer, whether a chest X-ray is sufficient, ultrasound abdomen is sufficient, or should you go for more, for example, internal mammary nodes in breast cancer, and also finer deposits in the lung, which may not be picked up on a regular chest X-ray. Is there a role? What is your role? Because as an examiner, would you accept chest X-ray, or would you want them to say just CT?
See, I follow for exam point of view ICMR guidelines. ICMR does have guidelines on CA breast for our population, sir. So if you read those guidelines, the ICMR guidelines are updated every 2 years. If I'm not mistaken, Ravi sir, there are ICMR guidelines. I would advise our students to read the ICMR guidelines. What does ICMR guidelines say? Chest X-ray and ultrasound.
That is sufficient.
Stage-wise.
That is sufficient.
Yeah, that is sufficient. If you say there are, for example, a medial tumor,
tool of investigation, chest X-ray and ultrasound are sufficient. But in case the chest X-ray or ultrasound points out to some anomaly or some doubtful, as you said, internal mammary nodes or some subpleural deposits or a small lung lesion, then always you have to get a CECT thorax. Follow it up with the CECT thorax. Likewise, in the ultrasound abdomen, if it is showing a small deposit in the liver, so you'll have to always get it confirmed with the CECT of the thorax abdomen in order to see whether it's really a MET or a hemangioma.
They're very clear-cut guidelines, sir. Our guidelines, ICMR and
the basic investigation initial tool of choice would be a chest X-ray and ultrasound abdomen.
See, this is what I wanted to bring this point clearly for the students, because there should not be any confusion. So as long as they can justify what they say, that is fine. Okay, Dr. Rajan sir, final comments. Sir. Final comments.
Yeah, I think that the poor lad was misguided by the fact that he knew the diagnosis and was going for soft tissue and for a gist in his presentation also. Two little things that I have left to say is the difference between bimanually palpable and ballotable. When you have a large lumbar swelling, please remember it is bimanually palpable because you can feel both anterior and posterior aspects of the swelling. If it is only felt with the posterior hand and not with the anterior hand, and you move your posterior hand upwards and you feel it with the anterior hand, that is ballotable. So ballotable is a feature of smaller swellings in the lumbar region, whereas large swellings become bimanually palpable with the antero-posterior mobility. That's what the inference is. So that is the only thing. And about this swelling, right iliac fossa masses, the more common ones that come in are ileocecal tuberculosis and carcinoma cecum, sometimes the rare chronic appendicular abscess. They are the primary diagnosis, but in all of them, these none of the features were present in this case. So we had to move out of the common ones to think of the unusual ones that come there. It's not a bad presentation, doc, but still you're not going to score very heavily. You may pass, but you won't get many marks.
Thank you, sir.
Okay. Thank you.
Thank you, sir.
I think Dr. Kanakavel, thank you very much for your excellent inputs, and all the faculty. I think they were extremely focused and very to the point discussion, and very practical and applicable points for all the students. Thank you very much, Dr. Ravi Arjunan, Dr. Pai, and Dr. Srivatsa, and Dr. Rajan, of course.
So with this, we come to the end of clinical case discussion. Now we move on to the OSCE part 2 by Dr. Laksman K. Sir, Laksman, sir.
Good evening. Thank you very much, Harish.
Yes, sir.
We will have a leisurely, laid-back discussion. Yesterday, I spoke about the principles of OSCE. Today we'll go through some practical questions. I know that they do not reflect the DNB pattern of questions. Okay, I have put these are all questions that I have set, and they're more in keeping with the MRCS part of OSCE rather than the DNB, because I know that DNB is evolving, and with time, as DNB questions get people get more experienced at setting these questions, and perhaps, as I said yesterday, as the MS people start using these questions, then they may also become more like what you're going to see today. So I have no illusion in trying to say that this is going to help you in your exam, but I'm very confident that it will help you in your practice as a surgeon, because all the questions are based on real cases and the way we see it in our day-to-day practice. In fact, I always feel when somebody say, for the sake of the exam you should say this, I am concerned with that statement. I think exams must reflect what we do in practice, and that must be evidence-based for everybody, whether you're doing it in an exam or otherwise. Because every day you practice, every single patient you see is an exam, is a test of your capacity as a clinical surgeon. To have some kind of, shall we say, discipline in the way we answer, can I have two volunteers please to take the first few questions, and then I'll start sharing my screen. Nobody volunteers. You can put your hand up, unmute yourself. 2 postgraduates please. Nobody? So can I call out names from the participant list, and if it happens to be a practicing surgeon or a consultant whose name is not familiar to me, kindly pardon me, don't take it as an insult. Okay, shall we say Anjali AB? Can you unmute yourself please?
Yes sir.
All right, very good Anjali, thank you for unmuting quickly. Dr. Shefa Hussain, are you there? Not interested. Okay, whom shall we call?
Dr. Prajwal Dutt.
Prajwal Dutt. All right, we'll go with what Ravi says. Prajwal Dutt, are you there?
I can see you.
Okay, let's go with Anjali and not waste time. As I told you, you have various kinds of OSCE. It may be an operative video, it may be an X-ray, it may be a CT, it can be a clinical scenario, it can even be about, as I said, soft skills like informed consent, conveying bad news and things like that. Okay, so let's go with a picture first. Here is a 69-year-old lady presented with intermittent abdominal pain in the lower part with distension and constipation for 3 months. Clinical examination was essentially normal. Okay, there's nothing to feel. Thorough clinical examination. What investigations would you ask for? Go on, Anjali.
Sir, on clinical examination.
Clinical examination is normal.
Yes,
investigation. Sir. Just see, you must also know that you have very little time in OSCE.
Yes,
so
sir.
you have to
write
these things.
I would
yeah,
like to go for basic investigations, sir.
Yeah,
And
list them.
An erect X-ray of the abdomen and ultrasonography of the
You normally ask for X-ray first, or do you go for blood test?
No, first an ultrasonography.
You go ask for ultrasound first, even before blood tests?
Yes, sir. Sorry. First, the blood investigations.
Okay.
Then we would look for
list. You see, remember, you have to write what you're asking. You're actually a consultant in a clinic, seeing this patient. So what are you telling your lab to do? Please. That is the approach, practical approach. Yeah, go on.
Yes, sir. First, I would like to order a complete blood count, sir.
Right.
To look for any changes or elevations in the total count, and also look at the differential count to rule out if it is an acute or a chronic etiology.
All right. I don't even want the explanation. Just tell me what are the things you're going to ask, okay?
Yes, sir.
You're going to ask for a hemoglobin, total and differential count, okay?
Yes, sir. Then a urine routine, sir.
All right.
Routine. Probably an LFT and an RFT also, sir.
All right. Go on. What else?
Then we would go for radiological investigations.
All right. Tell me, what are they?
ultrasonography of the abdomen
Right.
and pelvis, and an
Mentioned erect abdomen, X-ray.
Yes, sir.
I would buy that. Yeah. What else?
if
What
at
other tests would you do?
So if at all the ultrasonography and the chest, erect X-ray abdomen both are inclusive, then probably go ahead with the CT.
Okay. What else?
That's it, sir.
The question is that it need not necessarily be, all investigations at the same time, but the question is what investigations would you ask for? So you have to have a complete list, and you can even say plus or minus. So patient with a, an elderly lady with constipation for 3 months, what would you ask for, apart from the imaging?
Scopy, sir.
Yes. Okay. So that is the first step. In the first part of your question, you would be definitely asking for a colonoscopy. All right. Now, among other investigations, this is a CT. I have expanded it as much as I can. I'm sure you can see it well. The questions that go with this particular CT are: describe the salient features. What is your diagnosis? What do you think can cause this condition, and what is the treatment? Just describe it first. What kind of a section is it? CT.
Sir, it is a coronal section.
All right. Coronal?
It's a...
Are you sure?
Axial.
Anybody else?
Anjali, you're doing well. Continue.
Go on.
Yes, sir.
What? Yeah.
Then we have to comment on whether it is a plain CT or a contrast enhanced CT.
Okay, go on. Keep talking. Yeah.
So I would like to tell that it is a contrast enhanced CT, sir. And we can also comment that rectal contrast has been given in this patient.
Difficult to say. Okay.
Okay.
Yeah.
And
it could be oral also. What else?
Sir, we can see an area having multiple. It is a heterogeneous.
This is hitting you, right? So
yes,
what is
sir,
this?
yes, sir.
What is the appearance here?
It is a heterogeneous lesion, sir.
Okay.
Probably.
Just describe it. It's a bean-shaped heterogeneous thing with a very thick wall.
Yes,
what does
sir.
the thick wall consist of? You can see something sitting there. There's a little less dense tissue, and there's something inside. Again, just like an outer wall, there is an inside wall.
Yes, sir.
I'm giving you a hint there. So what is it? It is a bowel in bowel appearance.
Yes, sir. It's a bowel. Can we say that it's a thickening, sir?
Yes, it's a very thick wall. Yeah, it's a very thick bowel wall with one kind of density, CT density on the outside, a little less dense in the middle, and more dense, similar to the outside density on the inside. So it's a bowel in bowel appearance.
What is that called?
Okay.
Interception.
Yeah. So, and what else do you see? Don't stop there, because when you describe, you need to check all these things. There is something else that is standing out in this picture. What are these things that you see? I am circling it.
Lymph nodes, sir.
Yes, there are certain para-aortic small lymph nodes. And what is this I am circling? It's a calcified aorta.
Yes, sir, aorta.
All right. So what you're talking about is that it is an intersusception.
Yes, sir.
So what you then do is you have described the features. What is your diagnosis? You say it could be ileocolic, it's colocolic. It could be, we don't know. You just call it an intersusception. What do you think would cause this condition in a 69-year-old?
Sir, it can be a tumor, sir.
Yes, so it's very likely to be some tumor, and as I said, that is exactly why you would want to do a colonoscopy.
Yes, sir.
Remember, this is not an acute condition where you are expecting strangulation. 3-month history of constipation, and this is an actual patient. It's not imagined, and clinical examination was essentially normal. No tenderness, no mass, no nothing. Okay, so this is what you would do. What is the treatment? And this is the answer for you. All right. Routine bloods, see the whole works. You do all that. Bowel in bowel appearance on the right side of the abdomen, para-aortic nodes, calcification of the aorta. It's a colocolic intersusception. If you leave this colocolic and just call it intersusception, it's perfectly reasonable. And in adults, the leading condition is commonly a tumor. And so after adequate workup and diagnosis, presuming that it is a cecal carcinoma, you would do an extended right hemicolectomy. All right, that is the kind of answers you should give. This is the way. This is a picture. Basically, this is based on an investigation. Let's come in, please. Sharath, are you there? Why are you so diffident? How many people are there? I'm not with the screen sharing. I'm not able 42. To see it. 42. Yeah, at least 30 of them will be postgraduates. So why can't somebody else come?
Atish
Sharath,
Shetty.
Are you there?
Sir, Sharath is post PG. He's a cohort.
Post PG. All right. Somebody else?
Atish Shetty.
Atish Shetty. Nishant, I'll give you the job. Name one person for one question. Yeah.
Atish Shetty, he logged out.
Effectively.
He logged out. Good
No,
one.
sir. Sorry
All
for
right.
driving, sir.
All right. Stop driving, Atish. It's very dangerous to listen to me, particularly. You will have a crash. Pull your car to the side and start answering. Can you see the picture? A 62-year-old male underwent a diagnostic thoracoscopy for effusion with dyspnea with no symptoms of cough, fever or wheeze. Okay, he just had dyspnea and an effusion. The picture below shows the view as the scope was introduced and the effusion. There was a significant effusion. So we put the scope in and aspirated it, and this is the view we saw. Okay, so the questions are, I left it, I think some of you saw the answers anyway. So describe the thoracoscopic findings. What is your diagnosis? What is your differential diagnosis? And what would you do next to get a definitive diagnosis? Those are the questions. Okay, so I'll let you have another good view. Just describe it. One of the things that people should learn, students should learn to do is describe what they see. Okay, and so describe this view. This is a thoracoscopic view. Please say something.
Anybody else is fine.
Anjali, sorry, I think you're stuck with me today. Unmute yourself and start talking. But I'll tell you, you will be the biggest beneficiary. Yeah. Others are losing out on a good opportunity.
Sir, we can see a few white patches here, sir.
Yes.
And also it is...
see, it is involving both the parietal and the visceral pleura, right?
Yes, sir.
Surface of the lung, which is underneath here, that is the parietal pleura. So it's involving both. What do you think of the tissue between the white patches?
Sir, erythematous, sir.
Yes, it is hyperemic. You're very good, very good. Hyperemic. And would you say something more about this white patch? Is it very flat, or is it a little elevated, or is it excavated? Is it an ulcer?
It looks flat, sir.
It looks like it's a flat block, okay, and it is very irregular in size and shape. Different things are different like that. What do you call that?
Sorry, sir, I didn't get your question.
It is very irregular in size and shape, right?
Yes, sir.
So what would you call that when you have an irregularity? You would call it a shaggy, okay?
Okay.
It is not regular. The shaggy flat blocks are seen on both the parietal and the visceral surfaces. There is hyperemia of the pleura in between. So what is your diagnosis?
It is some lesion originating from the pleura itself.
Correct. I would buy that. So what would it be? Commonest. 62-year-old male.
Mesothelioma.
Excellent. So what would be your differential diagnosis?
Can we say that it is any inflammation of the...
Yes, why not? Chronic inflammation, even though there is no cough, fever or wheeze, it could be tuberculosis.
Okay.
It could even be secondaries from elsewhere. Okay? And without cough, fever and wheeze, tuberculosis would come last on the list. It is also expected of you to give the list in the way of occurrence, in the way in which it occurs. Okay, so I would say mesothelioma is the first, second would be some secondary, and third would be possible tuberculosis. In fact, in classical OSCEs, they may even tell you, give me 2 possible diagnoses or 3 possible diagnoses, and when you give them, if they are within a list of 5 or 6, you will get full marks. Okay, and what would you do next to get a definitive diagnosis?
Biopsy, sir.
Okay. Is that the only thing you do? You have a differential diagnosis.
Sir,
So you have to cover all bases.
Fluid analysis.
Sorry? Yes. And what would you do? What would you analyze it for?
Cell type, cell count.
Okay. ADA.
15.
Excellent. That's all there is to it. So you see, we have discussed these before. Send a pleural fluid for proteins, differential count, ADA, malignant cells, and take a biopsy for HP and IHC. Okay, and if this is a complete list, and even if you give 60% of this list, you will probably have done well in the exam. Okay, anybody else volunteering? Now that you have seen that Anjali has survived, and is anybody else ready to come?
Indumati Balakrishnan.
Indumati Balakrishnan. I'll skip this because I would want to show you something a little different. Okay, okay. A 50-year-old male presents to you with an RIF guarding and rigidity. Investigations confirm the diagnosis of appendicitis. You are now to take a consent for appendicectomy. Okay. So list the items of information that you would share with him as a process of informed consent. What are the recommended requirements in the process of taking an informed consent? What is meant by adequate disclosure? Indumati.
Sir.
Go on. Good evening.
Sir, about the what kind of procedure we are doing, I would like to share with the patient, sir.
All right. You will mention the procedure, okay?
And the upcoming complications.
Complications of the procedure, correct?
Chances of complications.
Yes, very good. Incidence of complications, very good.
And the risk of conversion from laparoscopic to open in case.
All right. Okay. And when you're talking about that, you have to talk about the advantages and disadvantages of laparoscopy versus open surgery. Okay. Next. What happens if you do nothing? Is the next one. Okay. If you leave it untreated.
Yes, sir.
And what are the alternatives available? Is surgery the only option? No. You can consider conservative treatment. Then you have to, I won't go into the details, but you have to tell him what are the downsides of a conservative treatment. And these are the factors, why you're doing it, what are the alternatives available, what are the complications, all right, and what happens if nothing is done. Plus the cost, of course, if you are in a private setup, you have to discuss the cost also. What is meant by adequate disclosure? Suppose the patient tells you this is significant because remember this happens in every single operation that you do, every single informed consent you take. The patient may tell you, she didn't tell me enough. She didn't tell me the kind of information I needed. So the courts will decide what adequate disclosure is. That is the context of this question. What is adequate disclosure? Can you possibly give every single complication of every single procedure?
No, sir.
There are some unknown. So the courts are logical about it. Sometimes they may be illogical, but that's rare. But there is a concept of adequate disclosure. So what does that involve? Okay, that involves the mentioning of common and grave complications. Okay, you are expected to mention the common complications of a given procedure and the grave complications of a given procedure. Okay, so this is a soft skill, but you can have OSCE covering these things. And as I said, this is a question that I have put with a picture and some questions. You will have a station where you will have an actor acting as a patient, and the OSCE question there reads, this patient is diagnosed to have an acute appendicitis, take an informed consent for the procedure. And you will have two examiners sitting there, maybe even one, just watching you talk to the actor. The actor will be trained to give you the kind of answers and questions, things like that. And at the end of every procedure, after you have done all the explanations, you have to do two more things for your informed consent process to be complete. What is that? Anybody else? Two more things you have to do. A, ask him if he has any further questions. Give him an opportunity to ask questions. And B, ask him some question to make sure that he has understood what you have told him. Okay, so those are the two things which you do, and you may think this is all theoretical, but you will have my colleagues sitting with me who will vouch for the fact that for every single case, I and my colleagues who do it, we always go through this process. We've been doing it for decades, and that is an important thing to have. Okay, next question. The half an hour is just to give you a little, a little view, a very brief, superficial view into this whole concept of OSCE, but I'm sure that we are giving you some representative questions. It's okay, 7:21 now. Maybe we have time for 2 more questions. Okay, we have, let me just move. I have lots of questions, but I'll go to the last one, which is something which I think our boys, yeah, okay, I'll go for this. Not the last one, but we'll go for this. Okay, anybody else, or is it going to be Anjali or Indumati?
Pallavi is ready, sir.
Pallavi, excellent. Pallavi, this is a 56-year-old male presented with melena. Upper and lower GI endoscopy were normal. The patient suddenly collapsed while he was in the hospital and underwent an emergency laparotomy. Okay, these are pictures at laparotomy. What is the procedure being performed? What do you mean by obscure GI bleed? The answer is in the question itself, as it were. What is the first step in the diagnosis of an obscure GI bleed? What are the various means of identifying obscure GI bleed, and mention one advantage and disadvantage of each method. Okay?
Okay.
Right. What is being done here? Just describe what you see in the picture. This is an actual picture of procedures we are doing.
Can you zoom in, sir?
I can zoom in.
This is they have been trying to inject some dye and using a gamma camera or something.
No, nothing. I don't have access to any of those fancy things. I've done a laparotomy. I have thrown some light into the lumen of the bulb.
Yes.
What am I doing? Intraoperative endoscopy. Okay, we use a colonoscope. Yeah, when the patient has collapsed, so there's no question of my asking for other tests. That's a part of the question, so I won't tell you what I'm asking for. I opened him up because the guy is unwell with a bleed, and so I have to get the diagnosis. I know the upper GI is normal up to D2. I know the colon is normal. I want to look at the small bowel. So we do a laparotomy, make a small enterotomy in the middle of the bowel, small bowel, and then work our way up towards the DJ flexure and down towards the IC junction, ileocecal junction. This is called an intraoperative endoscopy. So you throw light on the inside, that's why it sits like that. What do you think is happening there? I've shown, it's a giveaway. I've shown a little, I put an artery forceps there.
Yes.
What do you think is that?
I'm not sure, sir.
Yeah, just guess. It's good to guess. No negative marks. There is everything white and one little red circular patch there.
There's one segment which is highlighted, sir.
This is highlighted. This little regular, yeah. Yes. What do you think that would be? What are the causes of bleed, GI bleed in the small bowel that is not easily picked up? It's an AV malformation.
AV malformations, okay, sir.
It's bleeding. You can also see, when you see from the inside, just like you're seeing from outside, we can actually see on the screen, which is, the colonoscope, which is picking up the image, you actually see the bleeder from that. And what do you mean by an obscure GI bleed?
But
how is it different from an occult GI bleed?
This obscure GI bleed may be a recurrent or a persistent.
A bleed that is not diagnosed by upper and lower GI endoscopy is an obscure GI bleed. Okay, something that you don't pick up with an upper GI and a lower GI.
Okay,
when you do that, that is an obscure GI bleed. What is an occult GI bleed?
Occult GI bleed is usually there's
no bleeding, no melena, no hematoschisia. It is picked up only on fecal occult blood testing.
Yes, sir.
All right, not necessarily microscopy. It's a chemical test, right? The occult blood. So that is the difference between an obscure and an occult GI bleed. So what is the first step in the diagnosis of an obscure GI bleed?
Maybe a capsule endoscopy for the small bowel.
Yeah. Well, that's not wrong. Okay, but what you can do is sometimes you miss these lesions. Okay, if the patient has not collapsed, like in this case, if you have time, it may be better to repeat your endoscopy in lower GI. Okay.
RBC, radio iodine tax.
Yes.
Radiographic studies.
Yeah, correct. Very good. What else?
Then
not radio iodine.
Sorry, sir.
Technetium 99.
Technetium tagged RBCs.
Technetium tagged RBCs.
Yeah, it's not radio iodine. I missed you saying radio iodine. Technetium tagged RBCs. Look at this: angiography, conventional, or CT, okay, or a capsule endoscopy. And as I said, give one advantage and one disadvantage of each of those. Okay, but small bowel endoscopy, the big advantage is that it is not expensive. You know, all these things take time, are very expensive. This can be done even in even in an emergency. And so what I'm talking about is small bowel endoscopy, not on table. Remember that.
Yes.
Push endoscopy or a balloon endoscopy. That is, yeah, that is expensive, time consuming, and not easily available, and yield is about 70%. So one of the best things, I believe, cheap, can be performed by the surgeon, and very effectively so in diagnosing it in well over 80 to 90% of cases, is an on-table endoscopy. Okay, I have only 4 minutes left. Harish, next time you must give me 5.5 hours. All right.
So one day for asking, sir.
No, I will finish. I will finish on time, but I can't leave a session without this. Who will do it? Pallavi? Will you take this?
Yes,
yeah. Okay, 72. I'm sorry about this fellow here. Okay, 72-year-old diabetic female looking ill, presents with an upper abdominal pain of 24 hours and is seen to be tachycardic, tachypneic with a BP of 100/60. Okay. Clinically, she is dehydrated. Abdominal examination is remarkable. I should have finished it there. For some tenderness, from generalized tenderness. Okay. Yeah. Go on. I have given you 2 questions. What do you think would be your differential diagnosis?
Diabetic ketoacidosis.
Oh, very good. First think of that. Good surgeon. Yes. All right. You're actually correct. It's not wrong at all to think of that. Okay, go on.
Severe gastritis.
All right.
Pancreatitis.
All right. Think of some surgical condition. Ill, general abdominal pain. Some abdominal septic condition is possible. Diabetic.
Dehydrated. Any intra-abdominal abscess.
Yes.
Like
exactly. Yeah. I thought as a surgeon you would say that first, but I'm very glad that you entertained ketoacidosis as a differential diagnosis. You're right. What test would you ask for?
Sir, I had a clue for the blood gases here, so I picked
You will
up
definitely
that.
ask that. Yeah. All right. You will get a routine count. You will get a routine count to look after, rule out abdominal conditions. See, I have only 2 minutes.
Dehydrated, so RBCs and serum electrolytes.
Yeah, electrolytes, urea, creatinine, ultrasound examination, maybe a chest X-ray to make sure that there is nothing.
I would like to check the CBG first, and then also.
What does this ABG show?
Amylase, lipase also.
Amylase and lipase, correct.
To rule out the pancreatitis from.
Correct. Just give me, I have only 1 minute, so you have to tell me what this shows.
Yes, sir. The pH is it's slightly on the acidotic side.
Slighter, quite. I mean, 7.4 is normal.
7.3, sir. Bicarbonate is low, sir.
Yeah, so?
There's a base deficit.
Yes, so what kind of an acidosis is it?
So it is metabolic acidosis.
Correct, very good. So when there is a metabolic acidosis, you have a concept of an anionic gap.
Yes.
What does that tell you? What is an anionic gap?
It will point us towards the cause of the acidosis.
Correct. So if the gap is high, what does it mean?
It is a sorry,
yeah, if the gap is high,
H plus losing.
You're not losing H plus. Acid is injected into the system.
Yes.
2 common things are ketoacidosis, as you mentioned, and lactic acidosis that comes from hypoperfusion, mostly from septic conditions.
Yes, sir.
And if the gap is not high, all right, it is more likely to be a primary renal cause.
Yes.
We can talk about it in detail later, but it's 7:30, and thank you very much, everybody, for your patient listening.
Thank you, sir.
Yeah.
Thank you so much, Dr. Laksman, sir,
Yeah.
for the wonderful presentation. Now, we move on to the last session, the most important session for the postgraduates. That is a class on surgical specimen for exam going PGs by Professor Dr. Dayanad Viligi. Is a professor and head Department of Pathology, Bangalore Medical College. And today I'm honored to call him for this meeting. He's my teacher and he was a wonderful teacher for us. Because of him, we are today. So I welcome Dr. Dayanad, sir.
Thank you, Harish, for giving me this opportunity to, yeah. So I think the main, am I audible?
Yes, sir. Yes, sir, you are audible.
Okay, okay, thank you very much. So first of all, I thank Harish and entire group for giving me this opportunity, and I welcome all the participants. I won't be going in detail about the specimens, whatever I'll be showing, but thinking in terms of your examination point of view, I'll just guide you how you can go ahead and describe the specimen that is being kept in your exams. Okay, so it is very important for a surgeon to recognize the. Can I share this?
Yeah, please, sir. Please share your slides.
Screen share. Share.
Yeah.
Yes, sir.
Yeah. So it is very important for a surgery postgraduates or the surgeons to recognize the specimen, because at times on the table, you might have to take the decision by visualizing the morphology of the lesion per se. So if it is a benign, the approach will be different. If it is an inflammatory lesion, your approach will be different. And if you consider it as a neoplastic, particularly malignancy, you might be able to change your procedure further. The reason why it is very important for you to recognize at least a few basic morphology of the diseases.
Sir, can you reshare the screen, sir?
Reshare the screen?
Okay. Yeah, we are not able to see the screen. It is in the.
Okay. Yeah.
Just close it and reshare, sir. Otherwise, Sharath will do that.
Yeah, yeah. Zoom.
See it now.
Yeah, now also we are not able to see the slides.
Yeah, you're not able to see.
Yes,
okay, 1 minute.
I think there must be some bandwidth problem, so we can just share and he can.
Can we share the?
Yeah, I think you should share.
Nishant, will you do that or Sharath?
Nishant or somebody can do it.
Yeah.
Are you seeing now?
Yes, sir.
Yes, sir.
Yeah. Can I go ahead? Is it visible now?
Yes, sir. Visible, sir. Please, sir.
Okay. Okay.
So you will not be able to show with your pointer, so you will have to describe the specimen, sir, because somebody else is controlling the pointer.
Okay. Yeah. Done. Okay.
You tell next, sir. Or back. The Nishant will do the job.
Sure.
Yes.
So this is the specimen where you are seeing the normal the salivary gland structure here. It is like gray white with nodular appearance and tiny cystic spaces. This is what the normal salivary gland at one edge, and the other edge on the left and right hand side you are seeing the fibrofatty tissue. But between that you are seeing very well circumscribed gray white lesion. Correct. If you look into the lesion, you are able to appreciate the translucent areas here. So you're also seeing the gray white areas and the translucent area in a very well circumscribed lesion in a salivary gland. always suggest a benign tumor, because you are seeing varied morphology, translucent area also, gray white area also, that suggests probably what you're looking at is a pleomorphic adenoma. Remember, a very well encapsulated tumor or a circumscribed tumor, you will be able to enucleate the lesion. But usually in salivary gland, you won't be enucleating because the chances of the microinvasion across the capsule into the surrounding tissue is known in the salivary gland. The reason why the normal tissue along will be removed. Not just that, many of these malignant lesions like acinic cell carcinoma, adenoid cystic carcinoma are also can appear well circumscribed. The reason why it is very, very important for you to remove along the normal tissue also. So this is a picture of pleomorphic adenoma, one of the common benign tumor. We call it pleomorphic adenoma because we are seeing these translucent areas and you're seeing the pearly gray white areas. So the reason why we are calling varied, since it is showing varied morphology, we call it pleomorphic adenoma. Okay, so we shall go to the next slide. Yeah. This is a lumpectomy specimen from the breast. If you look at this specimen, it is also very well circumscribed tumor because the surgeon was able to enucleate the lesion. If you look into this specimen, it is gray white and nodular, firm in consistency, firm gray white nodular, and you will be able to appreciate numerous slit-like spaces. That arrow is showing the cleft-like or the slit-like spaces. So tiny slit-like spaces is the clue for you. So gray white, well circumscribed tumor, gray white, nodular, numerous slit-like spaces suggests probably what you're looking at is fibroadenoma, one of the common benign tumor of the breast. Remember, these slit-like spaces is because of the compression of the acini or the duct, which has resulted in the gutter-like structure. The reason why you are seeing that tiny slit-like spaces. At times, tiny cysts can also be seen, or the areas of tiny gray white areas can also be seen, probably suggesting the additional evidence like sclerosing adenosis and epitheliosis and the presence of tiny cyst-like transformation also. Next specimen. See, this is the same. This is also from the breast. Look at the specimen. The surgeon is not able to enucleate the lesion per se. Instead, you are seeing the adherent adipose tissue along. All around, you are seeing the adherent adipose tissue. That suggests the tumor is not very well circumscribed. Probably it might be infiltrating into the surrounding parenchyma. You look at the specimen proper, you are similarly seeing the same exaggerated pattern of what you saw in fibroadenoma. Here, the gray-white tumor, large nodules, and exaggerated slit-like spaces. The arrow, what is showing like beautifully slit-like spaces, which is much longer, much larger, within which you are seeing the large gray-white nodules projecting into. This is a tumor of phylloidous tumor. So it is nothing but a large fibroadenoma. But since it is showing the infiltrative, ill-defined margin, the possibility of malignant transformation you have to consider. Remember, the large size, infiltration into the surrounding parenchyma, the mitosis, areas of hemorrhage and necrosis suggest the possibility of a malignant phylloides here. We are not significantly seeing the heterogeneous areas or the hemorrhage and necrosis, but definitely it appears to be infiltrative in nature because the margin is not regular. Margin is ill circumscribed. That suggests the possibility of malignant nature in this. So you can call it as malignant phylloides tumor, or the old terminology, as we all know, the cystosarcoma phylloides. Okay. Next slide. Next specimen. Yeah, this is the specimen of simple mastectomy specimen. You're able to visualize the nipple, which appears to be retracted, and you're seeing the pudy orange appearance of the surrounding parenchyma. The next specimen, next section. Yeah. So this is the cut surface of which. See, it's a simple mastectomy because you're not seeing the adherent axillary pad of fat along. But if you look at the center, you're seeing a depressed area. the depressed gravite area. You look at the margin. Margin is irregular. It is infiltrative in nature, as if the finger, like fingers, it is infiltrating into the surrounding parenchyma. Remember? So if you look at the surrounding parenchyma, normal breast parenchyma, the lesion is depressed. This depression is because the tumor is probably rich in the collagenous tissue. During the process of fixation, it has condensed and it has retracted beneath the surface. And many a times you get to see the areas of hemorrhage and necrosis. So what you are appreciating here is an irregular gravite tumor, which is retracted from the surrounding parenchyma, which is showing infiltrative margin. That is a feature of serous carcinoma. Remember, margin is infiltrative in nature. Because the serous carcinoma is dense in collagenous stroma, it retracts beneath the surrounding parenchyma. Usually it shows areas of hemorrhage and necrosis. This is the classical presentation of a malignant tumor that's called the serous carcinoma breast. Okay, so this is also a specimen of the breast tumor. If you look at the margins here, the margins are round, bulging here, unlike the infiltrative nature what you saw in the previous specimen. Remember, the previous specimen, the margin was not regular at all. Here you can see the margin is regular and bulbous, broad in nature. So this is called the pushy margin. Unlike a benign tumor, this tumor also appears well circumscribed. So what is the other difference? What you're seeing here is, if you look at the surrounding parenchyma, this tumor is bulging above the surrounding parenchyma. This is the classical presentation of medullary carcinoma breast. Remember, it has got a pushy infiltrative margin. Margin is not very well circumscribed. It is circumscribed, but still has got pushy margin. And the cut surface is projecting above the surrounding parenchyma. This happens in medullary carcinoma because it has got very, very scant stroma. It is rich, has got rich cellularity. The reason why it protrudes above the surrounding parenchyma, which is soft in consistency. And so serous carcinoma will be hard in consistency, whereas the medullary carcinoma will be soft, brain-like consistency. It has got infiltrative margin. This medullary carcinoma has got broad, pushy margin. That is ill circumscribed. It is well circumscribed in nature. So that is how we differentiate a medullary carcinoma of breast from this serous carcinoma. So let us go to the next specimen. I think this is the specimen which is showing the partial gastrectomy specimen. You recognize the partial gastrectomy specimen where the proximal resected margin will be broad. If you look at the proximal resected margin, that will be broad when compared to the distal resected margin, which will be narrow. The distal resected come down at the lower edge. Here it is the distal resected margin, which looks very narrow. So this lesion, this stomach, the partial gastrectomy specimen, we usually cut open the stomach along the greater curvature. That is because the most of the lesions in the stomach you get to see in the lesser curvature. The lesser curvature is the area where the stomach gets exposed to all the noxious elements. The reason why the most of the lesions in stomach you get to see in the lesser curvature. Since we don't want to disturb the lesion per se, we open along the greater curvature. Now, if you look at the arrow is showing a neat lesion in the lesser curvature. How is this lesion? The edge of the ulcer is punched out. What do we mean punched out ulcer? If you are able to place a scale at the edge of the ulcer, it is in line with the surrounding mucosa. So as if you feel as if somebody has punched out the material from the stomach and removed. So if you keep a scale at the edge of the ulcer, it is in line with the surrounding mucosa. And look at the floor of the ulcer. It looks very clean. This is because the floor of the ulcer is very clean because it has undergone the peptic digestion. You look at the rugacities. The rugacities are radiating and converging at the floor of the ulcer. This is the classical description we give for chronic benign gastropeptic ulcer. The chronicity, because with the chronicity of the ulcer, the base of the ulcer shows the fibrosis. Once there is a fibrosis, it drags the mucosa towards the ulcer, resulting in radiating nature of the ulcer. So punched out edge in line with the surrounding mucosa, clean floor, radiating rugacities, as you are seeing evidently, is a feature of benign peptic ulcer. Okay, if you look at the next specimen, see here, the edge is everted, edge is rolled out. That suggests it is a proliferative lesion. It is a feature of malignancy where the cells are proliferating at a faster rate. So it rolls on the surrounding mucosa, rolled out edge, or the rolled out edge is a what's that heaped up margin. Rolled out edge is a feature of malignant ulcer. And if you look at the floor is very much necrotic. The floor of the ulcer is necrotic. You might get to see the areas of hemorrhage and necrosis in the floor of the ulcer. So sometimes if the tumor is infiltrating in the surrounding parenchyma, you might get to see the ironed out rugacities. Ironing out of the rugacities is because the tumor starts infiltrating the surrounding mucosa, which has resulted in the edema which levels up to the surrounding rugacity, and it appears as if it has been ironed out rugacity. So this is also a specimen of partial gastrectomy, which is showing a malignant ulcer. So this is the specimen of total gastrectomy, where there is a portion of esophagus and a portion of duodenum is also included. Look at this lesser curvature. You are seeing the large tumor, which is ulceroproliferative tumor, which is projecting into the lumen. You look at the surface of the tumor, it do show the furry appearance. The furry nature, the furry appearance, friable nature probably suggests it is a papilloid in nature. This is a classical example of papillary carcinoma you get to see in the stomach. So total gastrectomy, including esophagus, it is including. You look at the surrounding mucosa here, the mucosa is completely flattened here. You have seen the loss of rugacities here. Remember, the radiating rugacities is a feature of benign gastric ulcer. Hypertrophic rugacities is a feature of metastasis, whereas flattened rugacity is a feature of malignancy. Okay, next specimen. See, this is another example of the stomach where the rugacities is completely ironed out and there is a thickening of the entire gastric wall, giving a leather bottle appearance. This is classically you get to see in a type of gastric carcinoma called the diffuse carcinoma. The Lawrence classification, you do have intestinal carcinoma and the other one is diffuse carcinoma. The diffuse carcinoma can diffusely infiltrate instead of presenting like an ulceroproliferative growth or an exophytic growth, what you get to see in intestinal carcinoma. The diffuse carcinoma diffusely infiltrates the entire thickness of the stomach and giving a leather bottle-like appearance. This is a classical picture of leather bottle stomach, which suggests that is an intestinal diffuse carcinoma stomach. This is a segment of small intestine. If you look at the segment of small intestine, which is markedly thinned out, giving like parchment paper-like appearance. At the center, you can see the projection, the plateau-like projection or patch-like projections. That is because it is an hyperplastic pair patches, and in between you are seeing the oval ulcers. Remember, ulcer which is oval in nature and the long axis of which is in line with the surrounding intestine suggests probably what you're looking at is a typhoid ulcer. This is a parchment paper thinning, plateau-like, patch-like elevation of the mucosa with an oval ulcer, with a long axis of the ulcer is in line with the surrounding intestine. That is the feature of a typhoid ulcer. So this is again a specimen of an intestine structure. Come up, you are seeing an area of stricture. Yeah, arrow is pointing towards a stricture. Come down, there is an area of transverse ulceration. Come down, still come down. Yes, above. Yeah, there is an ulcer which is transversely placed. Like before, it was an oval ulcer. Here it is a transverse ulcer. Again, there is a small ulcer there. So there is an intestine which is showing the presence of stricture and the multiple ulcer. At places, the ulcer looks like a transversely placed ulcer. When you're seeing such a scenario, go back and look the serosal aspect. And the serosal aspect usually shows the multiple granules. That's called the tubercles. Remember, tuberculous ulcer can come in the form of ulcerative form. It can show stricture, and it can show tumefactive or big tumor-like lesions. So here is a specimen which is showing the stricture and the transverse ulcer. Transverse ulcer because in the intestines, the lymphatics runs in the transverse fashion. Lymphangitis is a feature in tuberculosis. The reason why the overlying mucosa is left off, and you get to see the presence of classical transverse ulcers in tuberculosis. Because it is a chronic ulcer, at times you can see the overhanging mucosa here. This is an example of small intestine where the serosa is showing a large, well-circumscribed tumor, and the cut surface of which is gray-white, tabaculated appearance, whorled appearance. That is in areas of hemorrhage also. This is a classical example of GIST, gastrointestinal stromal tumor. Remember, in small intestine, carcinomas are not common. Instead, the most common tumor is GIST, followed by carcinoid, followed by lymphomas, and lastly, the carcinoma. So when you're seeing a tumor which is firm, gray-white, fleshy, giving a tabaculated, a whorled appearance, your first thing should come to your mind is the GIST. The GIST, the gastrointestinal stromal tumor, is a feature which is very commonly seen in the small intestine. Remember, if the size is more than 10 centimeter, and if you are seeing the areas of hemorrhage and necrosis under the microscopy, if you are seeing the evidence of mitosis, that suggests malignant GIST. The single criteria is if it is size more than 10 centimeter, you should consider it as malignant GIST. So this is a segment where we saw an ulceroproliferative growth. Remember the ulceroproliferative growth projecting into the mucosa, almost completely narrowing the lumen. And if you look at the surface is showing the mucoid nature, and the tumor is seen infiltrating the entire thickness. This is a mucinous carcinoma of the intestine. Colonic mucinous carcinoma, which is completely projecting. It's a circumferential tumor, ulceroproliferative in nature, completely narrowing the luma, cut surface of which is gelatinous in nature. Carcinomas will be usually friable, gray-white, friable, with extensive areas of hemorrhage and necrosis. Whereas here, you're seeing the mucoid, gelatinous appearance that suggests probably what you're looking at is a mucinous carcinoma. Next. So this is a gallbladder specimen of cholecystectomy. We are seeing a large stone sitting inside the lumen of the gallbladder. So usually in chronic cholecystitis, serosa becomes dull, lusterless, because chronic cholecystitis invariably shows subserosal fibrosis, which results in the loss of shiny nature of this serosa. And the mucosa will still appear velvety, and you are seeing a large cholesterol stone beneath. Yeah, it is a large rounded stone with a granular surface. You can have a cholesterol stone, you can have a pigment stone, and you can have a mixed stones also here. The yellow nature, round with the granular surface, probably what you are seeing is a cholesterol stone with the evidence of chronic cholecystitis. Oh, this is the classical specimen of acute appendicitis showing a gangrenous change. So acute inflammation, appendix will be swollen, correct? Appendix will be swollen and edematous. Here you are seeing the appendix which is markedly swollen and edematous. And if it is other way around, you would have seen the congested vessels on the surface. Whereas here you are seeing the blackish discoloration, and you can see the exudate, gray-white exudate covering here. The gray-white exudate covering the serosa. So what? So swollen appendix, congested or blackish discoloration of the serosa, showing the evidence of exudate on the surface of the serosa, suggests what you're looking at is a gangrenous appendicitis, probably with evidence of perforation. Okay, next specimen. So this is an example of an intersusception, probably reduced in time. The reason why we are not seeing the gangrenous change. If you look at the apex, come up at the effect on the left-hand side, you can see the lesion. Here, at the opposite. Yeah, come up above, yeah. So there is the lesion. That is a polypoidal tumor. It is a front edge of the telescoping segment of intestine. It has telescoped into the distal segment, and it is surgery is done in time. The reason why the ischemic changes in the intersusceptum you are not seeing. It was a case of adenocarcinoma presenting as a sessile polyp, which has resulted in the intersusception, and the patient, we could appreciate, the clinician could recognize it early because of the presentation like intestinal obstruction, and the intersusception was released in time, and the reason why we are not seeing the ischemic change there. Okay, next specimen. This is the segment of the small intestine. If you look at here, you're seeing the normal mucosal folds. Come here, you're seeing this superficial serpentinous ulcer above, come above, right side, yeah, right side, yes, yeah, that area. If you look at that area, which is completely different from the rest of the areas here, this segment of the intestine, which is showing the cobblestone appearance. The cobblestone, can you see that right sided? Yeah, that is the cobblestone appearance. That cobblestone has resulted because of linear serpentinous ulcer, which the intervening normal mucosa is edematous and projecting above, giving a cobblestone appearance. If you look at the rest of the mucosa, it's showing the normal intestinal fold. So skip-like lesion with the presence of mucosal cobblestone appearance. And if you look at the serosa, you're seeing the creeping pad of fat. You come up at the serosa, you see here, come to the left. Yeah, that is the pad of fat which is creeping over the serosa. Remember, in inflammatory bowel disease, particularly in Crohn's disease, where you get to see the transmural inflammation, which has resulted in the which resulted in the inflammation of the entire serosa. To cover up this, the mesenteric pad of fat, the omental pad of fat covers up and giving a creeping pad of fat appearance. So cobblestone appearance, skip lesion, creeping pad of fat on the other surface, omental pad of fat, suggests what you're looking at is a Crohn's disease. Next specimen, please. We'll go to the next specimen. Yeah, this is a specimen of multinodular goiter, where we are seeing the multiple nodules being surrounded by the fibrous wall. And if you look into the nodule, you are seeing the variegated appearance. Where you are pointing is the translucent colloid, where you're seeing. The right side to that is the colloid, which is showing the evidence of hemorrhage. It's a translucent area, the colloid with hemorrhage. So the multiple nodule with the colloid with areas of hemorrhage and stromal fibrosis suggest what you're looking at is a multinodular goiter. Yeah, this is the specimen of lobectomy specimen, where you are seeing very well encapsulated lesion, so with a surrounding normal thyroid parenchyma. So very well encapsulated lesion probably suggests what you're looking at is a follicular adenoma. Remember, it is very, very important for us because even the follicular carcinoma can just mimic the follicular adenoma. Whatever the areas of hemorrhage, it might be because of an FNAC site, what you're seeing in the lesion proper. But you have to give the section from the entire capsule and make sure there is no evidence of capsular or the vascular invasion there. Okay, so this is an example where you are seeing the gray white nodule, which is showing the furry appearance. Furry means the papillary in nature and showing the cystic change. So this is a classical presentation of papillary carcinoma thyroid. It's still at one end, you can still see the normal thyroid parenchyma with the translucent colloid. Whereas the rest of the area, you're seeing the gray white nodule with the classical furry surface. Furry surface, cystic change, areas of hemorrhage suggest probably what you're looking at is papillary carcinoma thyroid. So next specimen is once again the papillary. So this is, see, one lobe, the small lobe of the thyroid, which looks quite normal. The other lobe, which is enlarged lobe of the thyroid, show variegated appearance. You are seeing the areas of large areas of gray-brown areas and areas of hemorrhage. At the one pole, you are seeing the areas of hemorrhage also and cystic change. This is an example of the poorly differentiated carcinoma of the thyroid. So malignant neoplasm of the thyroid. Next specimen. Oh, this was an elliptical piece of skin. You are seeing an ulcerated nodule, which is projecting above and with an irregular margin. and blackish color. This is a classical example of melanoma, malignant melanoma. Next specimen. Yeah, this is the specimen of hand where you're showing the ulceroproliferative growth, like pearly white ulceroproliferative growth. That is a classical example of squamous cell carcinoma. I'm very sorry I have to rush through because the time given was just 30 minutes. I don't know whether it was not possible to interact also with the rest of the student.
Yes.
Not sure whether I've justified my talk or not.
It's almost you are prepared our surgery postgraduate as a pathology examination, sir. So depth information you are given, the same clarity of speech you taught us like LKG students, sir. So since 20 years you have not changed the way of teaching. So really you made a difference, sir. Really,
you mean to say I've not improved? Okay, yeah.
So,
thank you very much.
Surgical Society Bangalore applauds your contribution and then this forum, sir. Thank you so much, sir. Thank you so much.
Thank you very much.
So we come to the end of the CSEP program. So on behalf of Surgical Society Bangalore, I thank all the faculties, moderators from Monday till today for your valuable time you are given for the CSEP program, and the guidance of all my senior surgeons, EC members, for their constant support and guidance, and the technical support by Dr. Nishant, Dr. Khan, Dr. Wasim. So without you, I think it was not possible. This technical program, it was not possible. And I have to thank Mr. Glenn and Mr. Kumar. They constantly with me from 4 o'clock to 9 o'clock. So to make this program to be a successful program. I congratulate all the postgraduates for their presentations. So wish you good luck in future. So Surgical Society Bangalore.
Hey, Harish.
Yes, sir.
Dr. Dayanad did a very good job. He was very, very clear in what he was trying to teach people. Point to point, he explained it very well. Well done, Dr. Dayanad.
Yes, sir. And also,
Harish, you have done an excellent job. You are thanking everybody. I have to thank you. You have done a very good job for coordinating the event for all the last 6 days. Well done, Harish.
You trained me like a soldier. So always I should be like this.
But
so
soldier has to perform, Harish.
So because of you,
soldier has to perform also. Okay.
Yes, sir. Thank you, sir. Thank you for your blessings. So
we'll see it tomorrow evening.
Yeah, shall I think I'll announce the tomorrow oration program. It is
oration need not be announced here.
Yeah, yeah.
Oration need
so
not
only
be
for the faculties and the members of Surgical Society Bangalore.
Okay.
Okay, sir. Thank you, one and all. Good night.